Shall we start, sir? Around 6 o'clock.
Yeah, definitely we will start. Just check with Lena because her talk will come quite fast. Amarnath will finish fast. Once Lena is in, then it's done.
I'm already in.
Sorry, good evening actually. Good evening, you are ready? You are ready?
Yeah.
Voice is little.
Okay, I'll just check.
We can't hear you clearly, ma'am.
Is it better now?
Yes, definitely better. Definitely better.
Yes.
Is there echo?
Little echo is coming. Is the phone is on?
Okay, I'll just take off the phone. How is it now?
Perfect, madam. Yeah.
Okay, Lina, just wanted to introduce all the other faculties here. We have Dr. Karmalkar from Indore, his senior most faculty, all of us. He is going to talk on ultrasound. And Lina yourself, consultant radiologist at CMC Vellore, and she is has done the main COVID-related talks for this year in a lot of all India forums. And she was really worried that the people will ask a lot of very detailed questions in the last year. I told them, no such people will be there today. So we will take care of you. We will protect you. Don't worry. And Murli, Amarnath are there. And Bavaharan, our leader at Trichy, is Samrakshan, excellent in CTMR and ultrasound. And we have Professor Dr. Sitaraman, consultant radiologist at KMCH. So both are going to talk on CTMR side of COVID because both has got a lot of cases which has come through recently. So now that we all know now, Murli, you can start the proceeding now.
Thank you, everyone. I think we are now live. We have about 50 participants already. So I think we will start the July monthly meet. At the outset, I would like to welcome Dr. Amarnath, President, Indian Radiology and Imaging Association, Dr. Anbarasu, the President of the Tamil Nadu and Pondicherry chapter of IRIA, and all the distinguished faculty and, of course, the delegates for participating in this webinar. Without much ado, I would like to welcome Dr. Anbarasu to give the introduction to the webinar.
Thank you, Murali Krishna, our secretary, Professor Amarnath, our National IRA president. Thank you very much for being with us today. It's an important step in this year because we are come to a stage where the COVID has come and gone temporarily, and then the post-COVID and complications have started occurring. And the reporting post-COVID CT of the chest is becoming tough, and also the mucormycosis cases are also increasing. And we also sort of, the ultrasound is being used in many departments where there is an important aspect where we have to actually show the ICU and ICU doctors what need to be done. So we have some distinguished faculty here. We are very thankful to Dr. Hemant Karmalkar from Indore spending his Sunday evening with us. And thank you, sir. And also Professor Lina from CMC Vellore is going to talk on CT chest. And we have our own Dr. Bavaharan who will be talking. He has given some excellent images for our IRA, ICRA guidelines. And also Dr. Sitaraman, who has compiled many of the good cases in this region of Coimbatore and Bavaharan and Trichy. So they are both going to share the knowledge in relation to CTMR. Thank you very much for all the delegates who are participating at the moment and those who will be joining soon. And now I leave to Professor Amarnath, who has actually made tremendous efforts here to bring out important guidelines related to COVID. And he's going to talk on that and also the general IRA and ICRA related activities. And thank you, Amarnath.
Thank you, Anbaras sir. Good afternoon to everyone. First of all, I thank the Tamil Nadu and Pondicherry chapter for IRA for organizing this CME on COVID. I thank again the President, Dr. Anbarasu, the Secretary, Murli Krishna, and other office bearers. And I am also happy to see the faculties of Indian famous all those, as Anbarasu told earlier, Dr. Hemant Kamalkar is there, Dr. Leena is there, Pavagaran, Sitaraman, and many more. So today we are going to get COVID-related updates from the topmost radiologists across the country. And in this time, I would like to say that IRA has brought COVID guidelines for abdominal imaging, neuro imaging, chest imaging, as well as the head and neck for the mucormycosis. And we got good feedback, and most of them are very useful guidelines. You can get A to Z of COVID imaging in chest or COVID imaging in mucormycosis. Everything will be nicely seen. So with this introduction, I want to just stress the chest COVID guidelines, where all the stages, how to report, what are the severity scores with the examples, what are the mimics, what are the complications, everything is covered with up-to-date reference. And I think definitely useful. Similarly, if you see the mucormycosis guidelines, we have given examples of all extents, orbit, cranium, nasal cavity, or the oral cavity, or the palate. Everything will be depicted nicely, so that you can see all the pathological abnormalities, invasions, intracranial extension, optic nerve involvement. Everything is nicely depicted in that guidelines. I think you can utilize this. And we are going to release 2 more guidelines on COVID. One is the radiation in COVID imaging. Another one is the safety guidelines for the radiologists, that will be released in a couple of days. And we are going to make a book on the entire all the 6 COVID guidelines, and will be circulated to all the members. I request everyone to go through these IRA guidelines. All the those really, I am very happy that many of them are brought from Tamil Nadu. I thank Dr. Anbarasu, Leena, and other team members, Bavagaran, all are contributing to the COVID guidelines. And also for the chest, Dr. Hemant Kamalkar also contributed significantly. I request everyone to utilize this opportunity and you make use of these COVID guidelines. Thank you all. I think you can continue with the COVID imaging. Thank you, Anbaras sir.
Thank you very much, Amarnath, for your kind words. Murli, please start.
Yeah. Thank you so much. I now invite Dr. Leena, who's from CMC Velo. She's a professor at CMC, and I invite her to talk on COVID CT and post-COVID CT sequelae CT. The current concepts, I know it has been changing over the months, and we have had several scores, grades, and now with post-COVID complications coming in, I request her to clarify the air and give her a presentation on it. Over to you, Leena, madam.
Thank you for the kind introduction. Is it audible?
Yes, ma'am.
So as mentioned, so I'll be quickly taking you through the COVID CT and the post-COVID CT. I think the COVID CT is something most of us are familiar with. So I'll be spending more on the post-COVID period, and I will quickly rush through the main points because I can't go to post-COVID without saying the COVID CT. So CORADS is something we all are so familiar with, and it's like kind of become like a bread and butter for the radiologists, especially the chest radiologists who will be reporting the COVID CTs, the COVID CORADS, which starts from 0 to 6, something similar to the BIRADS, which we often use it, or the TIRADS and the other similar classification reporting data system. Just to give examples, each CORADS 1, this is a emphysema, so this is CORADS 1, which is normal or non-infectious pattern, and the CORADS 2 when it is typical for other infections, like how we see here, there are TNPY nodules and consolidations, which is of other infections, and CORADS 3 when it is features compatible with COVID, but also can be seen in other disease, like how the peribronchovascular consolidation type of organizing pneumonia could be seen with other causes like drug toxicity. And when CORADS 4, when it is suspicious, when we are seeing either a unifocal or unilateral GGOs not reaching up to the subpleural, and CORADS 5 when it is a typical feature. And so we all know that the CORADS is from the Dutch Radiological Society, and just maybe 1 month before that, the RSNA has brought out their classification system, and we all are familiar with the typical appearance of COVID, which is the peripheral bilateral GGOs or the multifocal GGOs or the crazy paving appearance or the reverse halos. That is a typical appearance. And the indeterminate is when it becomes either multifocal, diffuse or perihilar, or when it is unilateral or a very small GGOs, not rounded. So that is the indeterminate appearance of COVID. And the atypical ones are when it is segmental or lobar or 3-in-bud nodule. So that is the atypical appearance. And putting the CORADS and the RSNA, we know we can see that the CORADS 1 is the negative for COVID pneumonia, and CORADS 2 is correlates with the RSNA atypical pattern. CORADS 3 and 4 correlates with the RSNA indeterminate pattern, and CORADS 5 correlates with the RSNA typical pattern. Now, the inter-observer agreement, when we compare with for CORADS versus RSNA, it is slightly higher for CORADS, 0.6 to 0.7, but both have very good inter-observer agreement. But one thing which we need to remember is this was developed in the acute stage of pandemic in the first wave when the Europe was hit by the pandemic. And at that time, and so the accuracy depends on the prevalence of disease. So this was made when there was a high prevalence of disease. And at that time, the patients didn't have residual abnormalities like how we see with a lot of post-COVID sequelae. And whether the system is sufficient for patients with mild or no symptoms has not been validated. Now, it's important when we write the CORADS to also to describe what it is qualitatively, because sometimes the clinicians may not know. Some people may think that the CORADS 1 is a milder form of COVID and CORADS 5 is a higher form of COVID. So we need to write what it means. If it's we feel if it's atypical pattern, we can write that also along with the CORADS so that the referring clinician knows what we are trying to convey. In that same line, there are also two other classification systems. One is the British Society of Thoracic Imaging System, which classifies into classic, probable, indeterminate, and non-COVID, and also the coronavirus disease reporting and data system, which classifies them as normal, chest CT, atypical findings, fairly typical, combination of atypical and typical findings. Now, these are not commonly used, and it's just for our knowledge that there are these systems also of classification. Now, coming to the CT score, now that is probably another most important thing which we should write when whenever we are reporting a CT of a COVID patient. So there are different scoring systems. So again, it's important that the referring clinician should know which scoring system we are following, because otherwise the numbers will not make any sense to the referring clinician. So this is this scoring system is 1 out of 24, and they have divided the lung based on zones, and again the lung involvement having a score from 1 to 4. And in the max, other scoring system is a 1 out of 25, which is the most commonly used scoring system in India and or probably more even across the world. This is the one where the lung is divided based on the lobes, and the lung involvement scores ranges from 1 to 5. Since all of you are familiar with it, I'm not going into the details of it. And in this category, we divide this less than or equal to 7 as mild, 8 to 17 as moderate, and more than 18 as severe. And then there is also a scoring system out of 40 where the lungs are divided based on the segments. So 10 segments on each lung, total of 20 segments, a score of maximum score of 40, and the lung involvement is given a score of 1 or 2. And then there is a scoring system out of 60. This is the only scoring system where the severity of the disease is also considered along with the extent of involvement, because they give separate scoring system for the attenuation, and they multiply the lung attenuation score with the lung involvement score, and that's how each score for the lobe is calculated, and adding up will give the maximum score for that particular CT. Now this scoring system is originated from the Ichikada scoring. This is the Ichikada scoring system, which is used for ARDS scoring. Now the Ichikada scoring system actually has it is a little more expanded scoring system. Now the question whether we can use this in the setting of the post-COVID fibrotic like changes or post-COVID sequelae is questionable, because it's a little complex scoring system. So in a daily practice, it may not be easy to follow it. So it's easy to do it during the active or the progressive stage, or when the COVID illness is, but when the post-COVID sequelae, it becomes a little more complicated. So it may not be very easy to follow this scoring system in the post-COVID CTs. Now, as I said earlier, the different scoring system will have different scores. Just to give an example, so this is a day 6 CT of a 61-year-old patient with COVID illness. So the scoring on the 25 scoring is 10 out of 25, because it's mild to moderate disease, not much involvement, but on the 60, it is 16. So if he just writes 16, he may think it is 16 out of 25. So we should write the denominator, which scoring system we are using. And also, between the scoring system, even the same involvement will have a different scores. Like here, because it's consolidation, it will give a score of 3 in the out of 60, whereas a score of 2. Now for both consolidation and ground glass opacity, the same type of involvement will have the same scoring system, but when it comes to out of 60, it will be different scoring system. Now the main use of doing the CT scoring, one is to understand the extent of involvement, and also for prognostication. So this famous article by Marco Francon, he had used the scoring system of 25 to prognosticate, and they found that scoring more than 18% has got a higher risk for death, both using the univariate as well as the multivariate analysis. And we can find that out also from this survival analysis curve, how there is a sudden slope going down when the score is more than 80. And they have also shown how the CT scores, there is significant difference in those with mild and severe disease, and mild and critical disease as expected. And in this particular article by Ann Lee, which had used the scoring out of 60, and he had also used to prognosticate. And in addition, he had also tried to separate them patients into 3 cohorts, that is subgroup 1, 2, 3, based on the initial CT scan timing. And what they found is a significant difference in the CT scores between the death and the survival group. And it was done in the subgroup 1 or 2, that is those who had their CT before the 10th day, or on or before the 10th day. And they also found there was consolidations were more in the death group. And in those who had the CTs done less than 5 days, the CT score of 14.5 had a higher sensitivity and specificity for predicting mortality. And in the subgroup 2, a CT score of 27.5 had a higher sensitivity and specificity for predicting the mortality. Just to give an example, so this is a day 6 CT, the same example I showed earlier. This patient went home after a week with no complications, and his score was 16 out of 60. Similar age group with comorbidities. And also we can see there is development of pneumomediastinum, and the score was also high, and he succumbed to death within 3 days. And this patient, the previous patient, had more ground glass, and here we are seeing more consolidation. And this patient again had comorbidities, and the score was also high, and this patient also succumbed to death. And in the scoring out of 40, it is found that the threshold for identifying severe patients is 19.5 with the higher, reasonably high, good sensitivity and specificity. Now, sometimes we see that different patients, they will be at different stage, but they will be having the similar scoring. Now, in this patient, we can see that this is in the progressive stage or even going almost in the peak stage, where a lot of consolidation with surrounding ground glass, typical findings. Now, this is probably in the peak stage for this patient, and it's similar involvement in another patient, but you know that this is in the absorptive stage. So not all patients will be in the same stage even at the same day. Now, this particular article, which is from the time course duration from the initial from the onset of symptoms, and where they have looked at the multiple CTs at different time points, and we can see how the progression of the symptoms and how it is coming down, how it is going to the absorptive stage. For some, there will be a sudden peak and then a sudden drop, whereas in some it kind of plateaued. So this is also something we should know. And again, one important thing to know is in the stage 4, that is once the resorption absorptive stage starts, even at that time, residual ground glass opacities can be seen, and in sometimes even residual consolidation. Just to give an example in that similar ground, so this is a patient who had CTs 9 days apart. In the first one, very minimal involvement, so 10 out of 60 or 5 out of 25, and then it suddenly peaks up. But even when it peaks up, what we can see is there is already atelectatic bands seen. Now, it's important to write those details also when we are describing, because it will also convey to the, so this patient actually had his symptoms coming up at day 12. So the question the clinician wants to know is it still progressing? Is it in the progressive stage, or is started having the absorptive stage? So looking at it, and we can see that the some absorptive stage findings have already seen, and this was also correlating with how the drop in the CRP and the D dimer. So this is important, not just the scoring, also qualitatively describing the findings favoring an absorptive stage versus a peak stage. Now, what are his associates? Especially in our country where TB is so endemic, we always used to say TB can be differential for any condition, and also here TB can be seen associated with COVID. So there's a patient who clinically is suspecting like TB, but it's just that it's all in the COVID pandemic era, and on the chest radiograph again it looks like a COVID X-ray, and it is confirmed on the CT, but the RT-PCR was negative, and the history was of hemoptysis also. So they were wondering, is there anything else also going on? Is it the TB also active in the disease? And what we found on expert TB PCR was also trace, and the pathology showed 2 vessel thrombus and pulmonary infarct. Now again, I've shown these arrows where we can see these dilated vessels, which is again almost like a telltale sign, or more commonly seen in the COVID pneumonia. So even at that time, we have suggested that these findings are there. Now, whether all the patients with the dilated vessels will have thrombi, or is it only microthrombi, we still are yet to see more publications, but this is again something at least we should know that small vessel thrombi may be there, or maybe even some cases it may be embolism. Now here the pathology showed the thrombosis, and it was also confirmed on the CT pulmonary angiogram, and the perfusion images also shows kind of a diffuse oligemia. So this is one associate. So we should, the common association of thromboembolism is something which we all have familiar with now, and the incidence varies from 6 to 30% in various articles. In CMC also, in those who had CT pulmonary angiogram with suspected thromboembolism, we found a 6% incidence. It may be varying in different setup and different categories. Now, this is another patient who had no history of COVID. In fact, patient came with complete heart block. So the workup was more with MRI cardiac and PET cardiac, and there was fair enough, there was uptake, nodular uptake, which was more classically like in a sarcoid, and there was also enlarged nodes in the mediastinum as well as in the axilla. Now, patient happened to have an X-ray done, chest radiograph done at 10th of June, and we can see the opacities in the lower zone, which is more towards the central aspect, and we can all and the CT chest done on 21st shows the atelectatic bands and reticulations, and again we can see these dilated vessels. Now, RT-PCR will not be positive at this stage because it's we know that it's already in the absorptive stage. It will not be positive, but we know that the patient had COVID illness, probably a milder disease. Now the question what we have to ask is the rhythm abnormalities, is it only of sarcoid? Is COVID also contributing it? We don't know. We may only get to know more answer with the follow-up imaging. This is a patient who had lymphoma and finished chemo on 12th April, and patient continued to have dry cough. So the question the clinician had, and then there was a sudden worsening of dyspnea. So the question the clinician had was, is it bleomycin toxicity or is it COVID illness? Now, if we look at the chest radiograph, we know that there is a sudden worsening happening here, and this is quite far apart from 12th April. So we know that this is unlikely to be bleomycin toxicity, and that was also confirmed on the CT. And but interestingly, the first RT-PCR was negative, and then they repeated it, that became as positive. And we can also see some fibrotic bands. It could be possible that patient had some bleomycin related toxicity because he's been having dry cough for some time, but definitely his acute component is the COVID infection. Moving to the post-COVID sequelae. Now, where I have shown the red square, that area is where we are looking. So we are looking at the parenchymal changes, the vascular and the pleural component. Now, this is taken from an initial article. So the word fibrosis is used. I know now we have seen more articles into it, and I will come more into those details. So when we, in the post-COVID sequelae, the questions we're asking, or what are the terminologies we should use? Or is it post-COVID ILD? Is it post-COVID fibrosis? Is it post-COVID fibrotic leg? If you look at the initial articles which have come up, they have used more of the word fibrosis. But now with more articles coming up after the second wave, the term which is preferred is fibrotic-like changes. But can we say the fibrotic-like changes? What happens even after 6 months if it persists? Can we use the word fibrosis? I personally feel if there are still fibrosis persisting beyond that, it may be we can probably use the word, but we still have to look at it carefully without branding them, because fibrosis also will convey that it is irreversible. So whether to use the fibrotic like or is the post-COVID ILD, we will look at some of the articles and we will get more knowledge into it. So this was a very initial article. The fact I want to convey from this article is, this is from the China way back in March. It's out of 70, 67 had residual disease, and out of the 67, most of them were pure ground glass. So this is again a question the clinician asks when they say pure ground glass in a post-COVID sequelae CT. Is it active inflammation or not? The answer is, depending on the onset of symptoms, we can say that this may be the residual or the post-COVID sequelae, needn't be an active disease. And in this particular article from post-COVID pneumonia, lung fibrosis, they have shown that people who have higher CT scores are more prone for developing fibrosis. And this, again, as I mentioned, this is an earlier article. So the word they have used is fibrosis. Now, these are the recent, a little more 2021 articles. So the questions, so interstitial lung disease after COVID infection, a catalog of uncertainties. I will put the things together in my follow-up slide. So this is probably one article which I found more useful, or something which we can get more information in our how to report. So there's a 6-month follow-up chest CT findings after severe pneumonia. So here what they have done is 114 patients. So they have grouped them into two based on the follow-up CT. That is, one group is those with fibrotic-like changes, and the other one is without evidence of fibrotic-like changes. And the patterns they look for are all these: ground glass opacities, consolidation, reticulation, emphysema, thickening of adjacent pleura, pleural effusion, nodules or mass, honeycombing. All these are the cytic patterns they look for. And when they termed as fibrotic-like changes, that is those CTs having traction bronchiectasis, parenchymal bands, and or honeycombing. Now, this was one of the examples from that particular article, and they have shown how the traction bronchiectasis and the honeycombing is seen, and also the thickening of the pleura. So these were the findings. When they see, they call it as fibrotic-like changes. And another finding they have mentioned is, we can see from day 9 to day 46, the ground glass opacities are persisting, maybe a slight decrease in density. And by day 159, there is significant reduction in the ground glass opacities. But if you look at each of those, look at the area of involvement, there is a slight increase in the extension of the GGO. So in this particular sign, it's called the melting sugar sign or the tinted sign. So this is, again, we often see it when the ground glass opacity, the density decreases, but there'll be a little more increase in the area of involvement. This again are two tables I want to show. So what they have shown, between the initial and follow-up CTs, which showed significant difference. One, the bronchiectasis were more in the follow-up CTs, the pleural effusion were more in the initial CTs, and of course the overall ground glass opacities, consolidation, and the total number of lesions, everything showed significant difference. And of course the fibrotic-like changes were more in the follow-up CTs. And in this, they have looked at time points of presence of fibrose or complete resolution. So this is in a nutshell, it shows that there is one group which showed the fibrotic-like changes, which is even at 6 months, even 55% of them showed fibrotic-like changes. And in the group 2, 31 had residual GGOs or interstitial thickening, and 53% of them showed complete radiologic resolution. One thing which I want to highlight from this article, this is published in Lancet. Again, the presence of ground glass opacities is seen even in the follow-up CTs, no matter what the scale of severity was. It's almost around 41 to 45% across, 41 to 48% in different clinical severity. The GGOs were still persisting, but the volume of GGOs have come down in the follow-up CTs. So what we have found is there can be complete resolution, there can be fibrotic-like changes, there can be small airway disease. Again, another article had mentioned about it. And also there can be residual interstitial changes. So just to give an example of each of them. So this is a patient who had COVID illness, and this is the 8th week. So in the previous CT, we know this is a typical, and it's more like a moderate involvement, but still on the follow-up CT 8th week, we can see complete resolution. Another patient who had, who also has in the background mild wheeze over the last 2 years, and patient continued to have shortness of breath even in the post-COVID period, and Spiro also showed restriction, and RV by TLC was also elevated. And even in this, along with the COVID features, we can also see there is air trapping even in the COVID CT. And in the post-COVID CT, what do we see? We can see that there is significant resolution of the findings, the COVID features, but the air trapping is still persisting. So there is significant resolution of the findings. Now, one interesting thing was this patient actually happened to have the myocarditis sequelae. Patient also had rhythm abnormalities, and that is how the MRI cardiac was done. And we can see there is still significant COVID sequelae in the myocardium. So the involvement or the sequelae in the lung needn't be correlated with what is happening in the myocardium. So here there are more myocardial sequelae, but very less lung involvement is persisting. Another patient, 47-year-old, who actually had a COVID ARDS. We can look at from day 10 chest radiograph up to the 18th June. We can see how it has progressed, opacities going into an ARDS form. He was intubated. And even at 18th June, and by 22nd June, the CT which done was to look for because of the high spiking fever. And we know the answer for it because there is ventilator-associated pneumonia. We can see the consolidatory pattern. But what I want to highlight is, so this is at the 6th week, and we can see that there is evidence of, along with the ARDS sequelae, we can see already the tractional bronchiectasis in these these CTs. So now one thing what we should remember from, so this is from prediction of pulmonary fibrosis for COVID-19. Now what they have shown is, so they have looked at the 3 set of CTs, initial CT, worst CT, and the follow-up CTs. So there is those in their worst CTs who already had bronchiectasis, they continue to have, that means there is not much difference even in the follow-up CTs, they continue to have the bronchiectasis. So some of, we see that a lot of these ARDS, people who go into ARDS develop the bronchiectasis much earlier. So they continue to have bronchiectasis even in their follow-up CTs. And of course, there was significant reduction in the air bronchograms, but there was not much significant change in the irregular interface or the coarse reticular pattern. But the parenchymal bands, again, there was significant difference between the worst CT and the latest follow-up CT. Now, from this study, what they have concluded is irregular interface and parenchymal band could be 2 early predictors of pulmonary fibrosis. Another patient with persisting dyspnea and uncontrolled diabetes, and on the follow-up radiograph, we can see patient also had a moderate to severe disease. And by 11 June, what we can see is a lot of fibrotic light changes. And fair enough, on the CT also, we can see a lot of atelectatic bands, ground glass opacities, reticulation. But compared to some of the previous CT, which I showed for another patient, we are not seeing that much of tractional bronchiectasis, but we are seeing a lot of this air trapping. So air trapping again is, and it may be seen along with the interstitial changes. So here we are seeing air trapping as well as residual interstitial changes, and also the perfusion scan shows mosaic perfusion. So that is also something which we keep seeing. All of these patients who have this residual interstitial changes or even fibrotic like changes, they tend to have persisting perfusion abnormalities. And another patient with COVID ARDS, again, we can see these air trapping. And again, this air trapping often will be more in the anterior aspect. As I mentioned earlier, the perfusion abnormalities is again something interesting, which I'm sure those who are already doing it would have also come across similar findings. So this patient's actually, the post-COVID CT shows very minimal interstitial thickening. But if you look at the perfusion scan, and his symptoms are still persisting. He didn't go into an ARDS pattern, but his perfusion abnormalities are still persisting, and he still has a lot of symptoms. So this is another thing. So this again is whether the microthrombi, how long it persists, all those things we are still in the research, and hopefully more papers will come out in this field also. Another patient. So if you look here, this post-COVID CT, it's almost like very negligible amount of changes. But if you look at the perfusion abnormalities, it is much more. So this is also another thing. The amount of fibrosis or the fibrotic-like changes or the residual interstitial lung changes, that doesn't equal with the amount of perfusion abnormalities. It often will be a little more. So another patient who in May 2020, he happened to have a chest radiograph. We don't know the exact reason why he had, but this is a 27th August 2020. Now these are images from outside our institution, which scanned into our packs. So this is when he had the COVID illness. We can see ground glass opacities more on the right side. And then he went on to have an ARDS with bacterial pneumonia. And that is when it's almost like the whole right lung is opacified. And then he came to our institution, and what we are seeing is a lot of fibrotic changes with tractional bronchiectasis, atelectatic bands, reticulations, and of course significant perfusion abnormalities. He didn't have any pulmonary embolism, and then he came for follow-up on 29th March, which is like 7 months from the onset of illness. And we are still seeing the same amount of fibros on the lung. We are seeing the same amount of fibrotic-like changes. So maybe it is time when it is so, it's prolonged for this many months, probably we can call them as fibrosis, because it has not changed. It is remaining. It has not decreased also. So maybe once it's there beyond 6 months, maybe we can call them as fibrosis. Another patient who also, this is the first chest radiograph during the time, during the illness, and we can see how quite moderate to severe illness was there, and his fibrotic like changes in the form of ground glass opacities, reticulation, tractional bronchiectasis is quite severe. It is much more than what we are seeing it on the chest radiograph. Now, often when we compare the radiograph with the CT, it will not match because we will see more findings on the CT. And here we can see also again there are areas of air trapping and also fibrotic-like changes. And the follow-up CT in fact shows significant reduction in the fibrotic-like changes, is showing significant reduction in density. But so one thing is the involvement has not changed, but the density has decreased. But in the perfusion scans, there is no change. So this is again to highlight that the perfusion changes takes time to resolve. Again, similar to during COVID, in the post-COVID also, this patient came with breathlessness after he was discharged. So again, we can see new onset of pulmonary embolism. This again is something which we need to be aware of. And of course, the next comes the mucorbit, which I'm sure all of you also would have seen similar cases. So this is a patient who has a typical mucor finding. He was treated outside and then came back with the chest radiograph showing a cavity, and that is when the imaging was done, and we can see a cavitatory lesion having the typical Birdness sign, and also it is infiltrating the extending into the left pulmonary artery. So it's a typical angioinvasive form of the mucormycosis, and he had some residual post-COVID changes were seen, and the culture group, both Aspergillus and the Rhizopus is the mucor group, and also the Klebsiella. So often, for the Klebsiella, we can see that there is some fluid level also forming. So often there can be some mixed organisms, and once they come into the hospital, they can also get other hospital-acquired infection. Another proven case of mucormycosis with the typical Birdness sign. Now, in this article, they have looked at the features between the pulmonary mucormycosis and the pulmonary aspergillosis. And what they have found is consolidations and ground glass opacities are more with the aspergillosis. And other thing is, another finding which I want to highlight is the Birdness sign is very classical for mucormycosis. So once we see that, whereas the other signs can be sometimes seen in others also, whereas the Birdness sign and the reverse halo sign is more common with the mucormycosis. So this COVID positive patient previously adequately treated, and also has diabetes, which is uncontrolled, then presenting with pleuritic chest pain and proptosis of left eye. Now with this combination, the first thing will be, is it invasive fungal? Now there was a cavitatory lesion, also there was post-COVID changes, but for this patient, we are not seeing the typical mucor changes, and there was also fluid level, and the culture grew Acinetobacter. So whenever we see a cavitatory lesion, so the two differential comes, whether is it fungal versus a gram-negative. So then look at the number of nodules, and are there any specific signs? If there are specific signs that give us more confidence to call it as, like if there is Birdness sign or reverse halo sign, then we can call them as mucor. The fluid levels are more common with the gram-negative bacterials, and often the gram-negatives will be single. Again, another patient, similar history with, again, a right orbital settling, facial pain. But again, this patient also, the culture grew Pseudomonas. And the post catheter was put into the cavity. And here there were some strands. Here one could wonder, is it actually developing into like a Birdness form? But so there was a suspicion raised, but again, we should always keep both the things whenever it's not very clear, and the culture grew Pseudomonas. Now, I just want to bring in this aspect of ARDS, especially when they have long COVID patients being in the ward. The question the clinician asks is it still, when they see ground glass opacities, the question is it still active COVID, or is it post ARDS sequelae. So we should remember that the COVID peak stage will not prolong for so long, and this is day 40 CT. And this diffuse ground glass opacity is often seen with the post-ARDS sequelae. Now, this article has come up, ground glass opacity, a review of differential diagnosis in the era of COVID-19. So in the, the marker has moved. So it is, I just want to highlight that this is in the ARDS, which we can rule out all the other causes. There are hemorrhage, edema, other causes of valvular protenosis, interstitial fibrosis. So if it is still diffuse, then we should think of ARDS. And also this was that same patient, if you look at the prior radiograph, this is someone who had severe ARDS also, and you can see it was more of consolidation. So once it resolves, it will look like the same, the radiograph at that time looked more clear, but this is how the CT will appear. So we shouldn't get carried away by how the chest radiograph is looking. We will be seeing more ground glass opacities, and this is the resolved form from the ARDS, resolving phase. This is a patient, just want to show two examples of with ILDs. So this is a patient who is known to have rheumatoid arthritis and was on treatment for it. And this is the CT of 4th June. We can see a lot of ground glass opacities, and some background changes of interstitial thickening is already there. And in the follow-up CT, we can see there is resolution of the ground glass opacities, and we can see the honeycombing and the traction bronchiectasis. And when we compare that with the pre-COVID CT done way back in 2019, we can see that it is in the same place we are seeing the fibrotic changes. And here, this is the interstitial fibrosis related to the rheumatoid arthritis. And we can see there is mild increase in the fibrotic change. So this is a ILD, already patient having interstitial fibrosis. On top of it, there was COVID, but what we are seeing as the fibrotic changes is part of the ILD. Another patient who had who had COVID illness in August CT. So in the outside images, we could see that already there is some fibrotic changes which we can appreciate in the upper lobes, and then there was this COVID typical feature seen. And then in September, the patient's COVID illness was in August, and this was a September CT. And then the patient came to our institution in November, and this is what we are seeing. So if we compare with the September CT, we can see there is a resolution of the consolidation with some ground glass densities and reticulation persisting. Patient was started on steroids, but unfortunately patient was non-compliant with it and came back in April 2021. And here we can see it's the same amount of fibrotic changes still seen. So here, from what we can understand is, and then when we looked at the history, patient also had some occupational exposure. So there could be an underlying ILD, which maybe something like a chronic HP was there in the background. On top of it was the COVID illness. Now, what we are seeing as residual changes, is it only post-COVID? It's likely that the underlying ILD is also contributing to it. This is a patient who had a COVID illness in 29th August 2020. We can see the September CT showing the vascular tree in bud appearance, and already there is resorptive changes are seen in terms of some tractional bronchiectasis and reticulations. And then patient continued to have symptoms, and patient came to our institution. And when we compare the June 2021 CT with what was there in the September 2020, the symptoms, the feature seems to be almost persisting. Maybe there is a mild reduction. And then we found out that patient's occupation is a coal miner, and that's why patient was also apparently having symptoms even before the COVID. And so from the COVID illness till the post-COVID period, if you see the radiograph, we can see that the initial COVID illness changes, there is residual post-COVID changes, the fibrotic like changes are there. And then when we compare with the pre-COVID CT, we can see that it is not like a completely normal. So definitely there was a component of occupational lung disease was there. He's a coal miner, so some amount of pneumoconiosis related changes were there. But what we are seeing as persisting is in the area where the COVID illness happened. So, and from September 2020, it is almost like 7th month. So maybe we can call it as post-COVID fibrotic changes along with the occupational lung disease. So to summarize, so we have seen how in the COVID CT, we should mention about the CORAD, CT involvement, and the CT severity scores, the COVID associate, COVID mimics we have seen. And in the post-COVID CT, we have seen the different radiological patterns, how the perfusion abnormalities persist even when the fibrotic-like changes have reduced or the residual changes are less. And we have also seen again the incidence of thromboembolism and ILD associated with COVID. So these are, I'm ready to take any question answers.
Thank you very much, Lina. That was very exhaustive, and we now actually can understand that post-COVID reporting is easy thing. Murli, I think we have a couple of questions. I also have a few questions jotted down.
Yes,
shall I
sir.
ask them?
Yes, sir, I think we can, yeah.
Okay. So there was a couple of questions when asking about ARDS and COVID. You already answered that in your slide in the, I think in the last 5-4 slides it was having.
Correct.
It actually presented initially with COVID with ARDS. And then when the ARDS was resolving, we started having chest X-ray showing near normal appearance, but the lungs are still showing sort of a appearance, filling both lungs. Is that right?
I didn't hear the last sentence, sir. Can you just repeat?
Yeah, you showed us case of ARDS in COVID, where the chest X-ray was abnormal and then it was resolving in the subsequent X-ray, while it was still showing some changes.
Yes. The question is in the CT there were still changes, but on the radiograph it is looking clear. Yes.
But if we don't know whether the patient actually had ARDS before,
how will we? Yeah.
How we will report that?
Yeah, I think it's. I think throughout the COVID illness and post-COVID, I think we need the clinical support. Without the clinical, I think we may have just looked at the X-ray and we may have even passed it on saying very minimal changes, or if we are seeing only that radiograph, it's very difficult. I think it's follow. If we look back at the prior imaging, the clinical, especially the clinical picture is very important. How it was before and how it is now. Just looking at one radiograph alone is difficult. Maybe on the CT it's little more when we see the diffuse ground opacities. At least there is a possibility among the differentials for diffuse ground opacities, ARDS will come. But on the chest radiograph alone to come to that conclusion is difficult, because ground glass opacity has on the radiograph will not be seen often.
Okay. That is actually the important point. Meaning, obviously, in a teaching institutions, there will be follow-up, there will be previous scans, you have packs. But when it comes to private practice, it's actually tough. So the key thing actually now, which at least I am following, is that we are asking every patient, is it your first CT or is it your follow-up CT? Because many of the time the clinical information coming in the private practice is almost nil. They will just say Chacha CT lungs and they set it off. They will not even write whether the patient already had COVID or follow-up COVID. We don't know that. So it's very, very important that we ask the either through radiographer or through the reception staff that whether this patient is actually a second CT or third CT. And if it is a second CT or third CT, we should make every effort to get that CT previously so that we should be able to compare and then give a proper report, whether we can actually able to tell whether the resolution phase or not. The other point is that, which Lina already said, that the CRP and D-dimer status, that is very, very useful in the follow-up. Lina, here is the question. Patient after 14 days or 15th day, we are still seeing some ground glass changes. The clinician will be asking whether it is resolving or not. Patient, they will say charged, but in this CT, you reported that previously it was CORAD, say 9 out of 25, and now you are reporting after 17th day, because like we know that 11th to 14th day it will actually reach the peak. So on 15th day, when you're doing a follow-up CT, you will be probably reporting instead of 9 by 25, it will go to like 12 or 13 by 25. But the patient otherwise well. So how do we handle this situation?
I think the 3 point, I think there was one, if we have started seeing some of the resorptive features, at least it will give us a clue that it is going towards the absorptive stage, it's not the peak stage. So in that particular case, when I reported, I mentioned that actually that, like, because the question there was, the clinician actually wanted to know whether, in fact, patient was on home quarantine, didn't even come to hospital. He was one of our staff, so didn't even start any of the treatment. They were a little more conservatively treating. But when the dyspnea started, that's when the second CT was done. And so the question was whether they have to start all the antiviral steroids, because otherwise they hadn't initially started. So then I mentioned about that findings of absorptive changes like atelectatic bands are also seen. So I said it doesn't look like though, I mean, it was a 19th day. So I said it looked more like the absorptive changes have started. And that day they repeated again the clinical markers and that kind of correlated. But if without that, to take a decision only based on the CT will be a little tricky, because patient often will have symptoms also, even though we may see, in fact, this patient, the symptoms started from day 70. Till then, in that actual peak period, he probably kind of bits, once it's moved from peak to absorptive stage is where he actually started having the symptoms. So to be honest, I find putting lab and the clinical picture is very important. But if there are any features where we are more confident to say that this is not only peak, there are some changes of resorption have seen, I think we should highlight that. At least then they can correlate with the inflammatory markers.
Okay. Okay. The other question is, does immunosuppression really change the patterns? Meaning, Dr. Jairaj is actually asking that you described.
When you said immunosuppression, you would have meant the steroids being given.
I guess so, yes.
Yes. Now, when it was given makes a difference. Now, whether the treatment, how much the treatment was given, and the severity of the illness, and when we are doing the CT, all these matters. So suppose patient had been given steroids much earlier, and then we are doing the scan, say at the 3rd week or 4th week, we may see, and often the patient can still be symptomatic, and then we may not see the active inflammation so much, but patient may be symptomatic depending on how the severity. So I mean, there are too many things acting on it. It's not just the immunosuppression, the comorbidities, how easily responding to it, how clearing is happening. Like in that article where we have seen the 21 patients, not even one single patient had, not two patients had the same graph. It's all 21 had different graphs. So that is also something which we deal with COVID. Every patient, we have to look at it carefully. Maybe the active consolidatory component reduces a little more faster with giving the immunosuppressives, but the overall involvement in terms of the absorptive stages or fibrotic light changes developing will not change. I found the active component may start reducing. That's what I have seen.
Okay, thank you, Lina. And the other question was that do we do CT chest for all patients with a bad X-ray on ARDS, or do we do serial X-rays as per the request of intensivists?
See, the number of CTs are extremely low. We actually did a rough, especially even in the first wave, it was like only in the post-COVID we had CTs, very few. It's almost like 0.0075 in the first wave. Second wave, it was a little more different. One reason is most of the severe ARDS patients will be in the ICU setup. So shifting will cause changes in their oxygenation and SpO2. So clinicians are more concerned about it, because if it is definitely going to change the management, they did it. Otherwise, it was significantly low. So in the severe ARDS, not at the severe ARDS, after severe ARDS is coming down, if things are still not settling down, then the question was, is it the post-ARDS sequelae? Is there any other infection happening? Or is it embolism, a new onset embolism happening? When those kind of questions were there, they did it. Otherwise, at the time of severe ARDS, they were only doing the chest radiograph.
okay, which is slightly different from what we do in our private practice, because most of the patients coming to private centers are we end up in doing CT scans. So we do have a sometimes the other situation where we do have difficulty is that patients patients suddenly having breathlessness. In fact, even today we had one patient suddenly having breathlessness, suspecting COVID. They come, but what we see is a pleural effusion, a very hazy ground glass peribronchovascular distribution, and slightly dilated cardiac chambers. So we tend to think it is either due to cardiac failure or sort of myocarditis sequelae of COVID. We sometimes don't know whether the patient actually had COVID in the past or not, or in the recent past or not. So how do we approach such situation?
I think I feel in India in general, the imaging on the cardiac is less compared to how it is happening outside due to various reasons. In this particular scenario, I feel it is probably the COVID sequelae in the cardiac is the likely. So we should do cardiac MRI in this particular scenario. The cardiac myocarditis or the coronary spasm, one of those sequelae we will find because it's especially with the pleural effusion and with the dilated cardiomyopathy. Only other thing is whether patient already had idiopathic dilated cardiomyopathy or any other cause of dilated cardiomyopathy, we need to rule that out. But definitely in this particular case, I feel doing the cardiac MRI will be more beneficial along with the echo and ECGs.
Okay, and the last question, in some patients, we got the ground glass changes which are subpleural in distribution. In the next couple of scans, you can start seeing this has become more linear and atelectatic parenchymal band-like areas and started moving away from pleura. In 2-3 patients, it started initially it was few millimeters, and then it was almost a centimeter or two away from the pleura. So does it imply fibrosis, or what is actually the lung which is between that particular opacity and the pleural surface that become more like a hyperinflated and more like a COPD-like appearance in that particular area? What is the pathology behind it?
What I have seen when we do the perfusion anomaly, perfusion angiogram in these kind of situations, the atlantic band actually shows hyperemia, and the area with the emphysema will show oligemia, or almost in some patients it will be like perfusion defect. So to me, what I understand from those and from the article which was published in Radiology Cardiothoracic Imaging, so it is that microvascular thrombi which still has not completely resolved. And sometimes you see the next scan, if you see there may be some few from that completely emphysema change. In some patients, you will see 1 or 2 vessels going through it. So maybe if they start in our institution in one particular department, they do give the aspirin. It's again all our research related. It's not completely confirmed. So they assume that the inflammatory thrombus will be relieved by giving the aspirin, and we have seen improvement in those areas with aspirin. Now again, these are not published data yet. I think in the clinical trials are still going on, so I can't say this is definitely this. And again, postmortem reports are there showing that these are all inflammatory microthrombi, but whether what we are seeing in perfusion angiogram is the same thing, we still have to get more publications. But what I've understood was it was the inflammatory microthrombi related change. That is why that area is looking more loosened, and then you will see that fibrotic band. So that will be that fibrotic band area will be the area where initially would have had the hyperemic halo. So that hyperemia still persists, and then the oligemic area, which corresponds with the loosened or the emphysema-like appearance on the CT.
In the subpleural areas.
Subpleural.
Sir, I think we are almost 20-25 minutes behind schedule, sir. So yes. I think we'll go on to the next topic.
Thank you very much. A lot of people are saying thank you and excellent talk and everything on the
yes.
Thank you very much, Lina. Murli, please take care.
Thank you, sir. Now it's my pleasure to welcome Dr. Hemant Karmalkar to talk on the ultrasound of COVID. I think this is something very unique to our webinar. Usually, ultrasound is not much performed for COVID, but I think sir has got a valid point for the same. Hemant sir, all yours.
Sir, you need to unmute, sir.
Okay. Am I audible now? Yeah.
Yes, sir. Yes, sir. Yes, sir.
Okay.
You're audible, sir.
Right.
Yeah.
So, very good evening, all of you. It's my pleasure and privilege to be a part of this short symposium today. And at the outset, I thank the organizing committee and my special thank to Dr. Professor Amarnath, to Dr. Anna Barsu, Dr. Murli Krishna, and my local friend, Dr. Shiva. As you all know, I'm going to talk on use of lung ultrasound in COVID patient. And what I plan to do in short time, 20 minutes of time, to cover these artifacts, the basic protocols, some non-COVID lesions that we ought to know in order to differentiate them from COVID pneumonia and of course COVID. So let's begin with a video clip. This is a simple video clip that we see day in, day out in our practice when we are doing abdominal ultrasound. And this is the right lobe of the liver. And this white line, as you see, is a diaphragm. And what I want to emphasize is that there is a band of echoes. Okay, this got stuck up somewhere. Okay, anyway, there is a band of echoes, the curtain-like band that is coming and that is obscuring a part of the liver. And this basically is arising from the lung. And this is called as a reverberation artifact. You can see multiple horizontal lines in it. And so one thing is sure that if we are going to use ultrasound for lung imaging, then we have to learn to decipher different artifacts that are generated, since we cannot directly see the lung parenchyma. As far as the machines are concerned, well, any machine is a good machine for lung ultrasound. This 25-year-old my machine also does a very good job, and it is equally good in like this modern machine. And in fact, the modern machines have some disadvantage in that they have the algorithms and softwares to suppress the artifacts. And since we are dealing with the artifacts, we usually should turn off those fancy items like those harmonics and compound imaging and all those things. We don't need that for lung imaging. As far as the probes are concerned, well, these are the basic probes that we need for lung ultrasound. And this convex simple probe does everything when we are looking at the lung. And sometimes you need this superficial, for superficial structures like pleura and subpleural lesions, we can use this one. And these are the modern machines. These are handheld pocket machines, so-called point of care ultrasound machines, the focus machines, and they can be, you can carry them in your pocket. Of course, we are not going to see them in our part of the world for the simple reason that the stringent PCPNDT laws. So why are these artifacts produced? Well, basically the lung is a mixture of air and fluid, as we all know, and there is acoustic difference between these two elements. And these, when its pathological changes result in alteration of this ratio, and they generate particular type of the artifacts. For example, normal lung is almost air, pneumothorax will be full air, interstitial syndrome would be having mostly air and some fluid. In lung consolidation, you have mainly fluid, and when there is a pleural effusion, there will be all fluid. So all of these conditions would produce different ultrasound pictures. So something about the normal lung and how we see a normal lung on ultrasound. So these are the ribs, the intercostal muscle, the visceral pleura and the parietal pleura. And when you put your probe between two ribs here, you will see a thin line that is continuously moving. And this thin line is usually half centimeter below these ribs. These are the ribs, and this is pleura. Not only that, you will see another line that is parallel to this line, and this line is usually called as A line. And you will also notice that this A line is equidistant as a distance from transducer to the pleura to this A line. And this particular appearance is likened to bed sign, And that seems to be a really good imaging. This looks like a bat. So these two are the ribs, and the space between them is intercostal space, and the body of this rib is the pleura. That's a great imagination. And when you put M mode cursor on the normal lung, when the pleura is moving, this is what you get, the appearance. So this granular image that you see has been likened to sand on the beach, and this is a normal phenomena when the lung pleura is moving. And this is called the sandy beach sign. This is called the sandy beach sign. And when the pleura is not moving, what you get is this. And this is called as the barcode. This is called as barcode sign, where the pleura is not moving, and then it looks like a parallel lines that you see all over this thing. The conditions that restrict the pleural movement, and with the pleural absence of the pleural movement, is a pneumothorax, and ultrasound is very sensitive for that. So coming to A lines and why these A lines are produced. Well, let us try to understand the basic unit of the lung, here. And this is interlobular septa. Interlobular septa, you can imagine this to be a thin bag which contains millions of tiny balloons, which are tiny alveoli. And to peg these balloons, you have a packing material all over, which is interstitial tissue. And to reinforce that, we have intralobular septa. So this is the basic unit of the lung, and most of the pathologies which we are talking are involving this part of the lung. So when these alveoli are full of air, that is when the lung is normal, you get these A lines, which are horizontal lines, which are equidistant from the skin to the pleura, and these are called as because of the reverberation. This is the reason we get A lines. A lines are normal lines. So the normal signature of the lung is the pleura is sliding continuously. It is thin, linear, and smooth. You have A lines below the pleura, and at the base of each lung, you will see the curtain sign that we saw in the first video clip. So this is the normal signature of a normal lung on ultrasound. However, there are exceptions to the rule, and this is COPD and asthma. If your patient has a COPD or asthma, the patient can have normal lung signature. Rarely pulmonary embolism patients will have normal lung signature, and these are the rarest of the causes, non-pulmonary causes, which can be neurological, neuromuscular, or acid-base disbalance, which can cause respiratory problem, and yet the lungs will be normal on ultrasound. Coming to the pleura is the most important thing for us. All ultrasound signs arise from the pleura. And the good thing for the people, the sonologists, is that most of the lung pathologies reach up to the pleura, but not all. And for that matter, we are not going to beat CT, of course. The pleura has two layers, the visceral layer and the parietal layer, and the sound cannot show them separately. Anatomically, the thickness of the pleura is 0.2 to 0.4 millimeters. But when we see on the sound, the thickness, there is artificial thickening, and maximum thickness of a normal pleura is taken as 2 millimeters. So when the pleural thickness is between 2 to 3, that is a gray area, but mostly it is abnormal. And when it is more than 3 millimeters, this pleural thickening is definitely abnormal. We are not going to continuously go on measuring the pleura in every patient. Simply looking at the pleura, eyeballing it gives usually enough clue. But if at all we want to measure it, we can do it by zooming the image and putting the focal length at appropriate level, and then measuring the pleural thickness from outer to outer margin. In this case, we can see it is 1.35 millimeters, and this is a normal pleural thickness. Well, we will talk something about the B lines. The B lines are bad lines. These are abnormal lines. These are vertical lines which are laser-like. They arise from the pleura, and they are produced because of the thickening of the interlobular septae by any disease process, be it edema, be it inflammatory disease process, or be it neoplastic. All these B lines arise from the pleura, never above it. These B lines usually move with the pleura, and the most important character of these B lines is that they should extend down up to the periphery of the field, down up to the periphery of the field. And please remember, if you see more than 2 B lines in one intercostal space, it is usually pathological. It is usually pathological. So this is an example of B lines from a COVID patient. And here we can see these laser-like vertical lines, echogenic lines. These are arising from the pleura and reaching up to the peripheral part of the lung. And if you are a keen observer, you will also notice that in the same intercostal space, you have a normal pleural thickness here, normal pleura, no B lines, and on the contrary to that, you see A lines. So in the same picture, you see B lines and A lines, and this is because the skip lesion that occurred in COVID. So these are the spared areas. So in COVID patient, this is the usual in early stages. This is the hallmark of the beginning of the COVID pneumonia. Well, there are some mimics of the B line, and we should be aware of them. These E lines are emphysematous lines, and they are not difficult to differentiate. The real problem comes with the Z lines or the Z lines, which are the great mimicker of the B line. But please remember that these Z lines are very short, and they don't reach to the far end of the screen. And they are less echogenic, and also they do not show a synchronous movement with the pleura. So any vertical line which is not reaching to the far end of the screen is not a B line. Please remember this. If you have bilateral B line in a patient, this could be because of the pulmonary edema. This could be because of the diffuse interstitial pneumonitis, infections, or in ARDS. And of course, you can have patients with ILDs with diffuse fibrosis. These are three main basic causes for having bilateral B lines. If you have unilateral B lines, the patient can have a focal pneumonia, atelectasis, lung contusion, pulmonary infarct, or malignancy. So, something about the protocol. What protocols to follow when we are doing lung ultrasound? There are many protocols from 3 to 14 zones per lung. 3 to 14 zones per lung. But the best thing is to tailor your lung ultrasound according to the need and presentation of the patient. Dr. Lichtenstein, who is considered to be the pioneer, the father of lung ultrasound, suggested in his blue protocol, the blue stands for the bedside lung ultrasound in emergency, to see only 3 zones per lung, and to also watch for the A lines, B lines, consolidation, interstitial syndrome, effusion, and he also includes in this blue protocol to look for upper lower limb, deep veins. And with this simple 3-zone protocol, one can diagnose many conditions of the lung, one can differentiate conditions. But I would like to tell you that as far as the COVID, this protocol is not so good. And what protocol we follow is the 6-zone protocol. This is the basic one, and it is fast, and you can do this quickly. So 2 zones anteriorly, 2 zones laterally, and 2 zones posteriorly. So we have 6 zones for each lung. And as the CT people are doing scoring, you can also do scoring by adding all the zones and finding in that. We also have 28 zone protocols, but we are not going to talk about that. Well, one more important thing about this point, Dr. Lichtenstein is very fond of this point, and it is called as PLAPS point, or a posterolateral alveolar pleural syndrome point. Big name. And we have, it is found by the upper border of the diaphragm and at the junction and the mid-clavicular line. So when you put your probe, you can see the right lower lung and the lower zone. And most of the disease processes begin here. And it is very true for the COVID, because COVID usually involves the inferior basal and lateral portions of the lung most of the time. And so this point is very important. And when you are in hurry, or you want to do all complete examination, at least you can use this point and see the lung as much as possible and make a diagnosis. Now we'll talk something about consolidation. Well, you may be wondering in the COVID talk, why am I considering the consolidations and all those things? But we have to have basic idea about this, because they come into the differential possibilities, and we need to understand how to differentiate them by lung ultrasound. So in consolidation, what happens, the alveoli are filled with the fluid, as in pneumonia, and sometimes there is an associated collapse. So what happens, the lung parenchyma is seen almost like a liver, and it is called as the hepatization of the lung. And we have three patterns of the mnemonic consolidation, as we all know. Lobar consolidation, when a large part of the lobe is involved, and usually the bacterial invasion is the cause of that. Then we have segmental, only a part of a lobe is involved, and when only a part of the lobe is involved, the margins become very irregular because they merge with the normal lung, and this usually is called as charade sign for this segmental consolidation. And then lastly, we have alveolar pattern, where there is a when it is seen in bronchopneumonia, and it is due to the viral condition. This alveolar pattern is the most common pattern seen in COVID patients, most common patient in COVID patients. So ultrasound will show in consolidation the hepatized portion of the lung, which looks solid, and within that you will see air bronchogram. And the characteristic of this air bronchogram is it is a dynamic one. That means you can see little movement of air bubbles in it. It can also be associated with small pneumonic effusion, and rarely you can have some necrosis in this consolidated lung or abscess formation. Remember that this effusion is not usually hallmark of COVID. Okay, this is an example of basal consolidation. Here the part of the lung is looking like liver, completely consolidated, and within that you see this little tiny bronchi containing air, and the same patient where you can see that this air is slightly reaching up to the periphery. This is because of the movement of the air within it, and this is how the consolidation classically looks when we do lung ultrasound. Oh, well, I'll skip this. Well, then we have small segmental consolidation, and this is how it looks like. This is a segmental consolidation, and you will note that the margins are irregular. They are merging with the normal lung. This is slightly bigger. So actually this patient had a bacterial infection, pneumonitis, and you can differentiate, because in COVID also you will get subluval consolidation. But in COVID, size is slightly smaller, usually smaller than 3 centimeters, some smaller than 3 centimeters. And if you have bigger than that, possibly it is not COVID consolidation, but possibly other bacterial causes. There was some associated effusion in this case, also. Okay, so now we come to another important thing which we call as interstitial syndrome. Well, interstitial syndrome is the word which we imaging people use, but in the clinical world, they are not using this word. And it simply means that there is a diffuse lung parenchymal involvement at the level of the interlobular septa and the intralobular septa. And it is affecting the alveolar epithelium. And this happens because of the thickening of this interlobular septa. And the causes of the thickening are basically 313. The first is pulmonary edema. It can cause the interstitial involvement, and pulmonary edema can be hemodynamic, as we see in congestive cardiac failure or fluid overload, or it can be permeability induced, as we see in ARDS. Secondly, second cause of involvement of the interstitial part of the lungs is pneumonia. And third, of course, is lung fibrosis, as in connective tissue disorders, and rheumatoid arthritis, scleroderma, and all those things. So these are three basic causes of involvement of the lung. And we need to understand their appearance on ultrasound. So in order to, we can differentiate them from COVID pneumonia. So B lines are the hallmark of the interstitial syndrome. So we know how these B lines look. Now we will be talking about types of the B line. So basically there are three types of the B line. The first is called as septal rockets, and these B lines are separated by each other from around 7 millimeters. So there is a separation by 7 millimeters. So in each intercostal space, you can get 3 or 4 horizontal vertical B lines. When the number increases more than 5, they come closer, and then they are 3 millimeters apart. And when you get such B lines, it means that the disease process has reached up to the alveoli. In this, the disease process is up to the interlobular septa. In this, it has reached to the alveolar compartment. And when you have innumerable B lines, then what coalescent B lines, so what happens, the lung behind it becomes like a ground glass. Well, the ground glass is used by CT people, but just to make you understand, I use the word ground glass. So the lung looks white lung, you can call it, or you can call it light beam like lung. So you cannot see anything beyond that, and everything looks white beyond that. And this is an example of these three types of this thing. This is from the COVID patient, and he was worsening. So when he presented, he had this picture, a slightly thickened pleural line as we see here, and few B lines here. Then we come here and we see slightly more B lines because of the increased involvement. And then we have coalescent B lines, innumerable B lines, and the lung look ground glass or white beyond it. So the three basic types of the B lines, and each denotes different part of the involvement of the lung depending on the pathological process increasing. A few words about the ARDS. Well, ARDS and COVID pneumonia are different. But of course, we need to understand that 40% of the COVID patient can develop ARDS. So this is one patient who was thought to be having COVID, and he presented with this X-ray chest image. But after 3 days, he started worsening, and this is the X-ray, and it is showing diffuse alveolar infiltrate, interstitial alveolar infiltrate bilaterally. So how are we going to differentiate this ARDS picture, which is non-COVID, from the COVID-induced pneumonia? The basic difference is the timeline. The classical ARDS, which is non-COVID, usually develops before 7 days of the clinical symptoms, before 7 days. And in COVID patient, if they at all develop ARDS, it is usually after 8th day. This is one point. And the second point is the distribution of these opacities. In COVID, most of them are usually congregated in the lower zone of the lung, in the peripheral part. But ARDS has no boundaries, and it involves the whole of the lung in the central and other parts of the lung. And when you put probe on the different part of the lung, this is what we picture we get. The thickened pleura, which is irregular, large number of B lines, which of different types all over, and the whole of the lung in all the zones are involved. And you can see diffuse B lines, almost giving ground glass like appearance behind pleura. And this is the classical picture of ARDS. Something about the interstitial lung disease, known patient of the scleroderma. You can see diffuse interstitial and alveolar changes in both lungs with fibrosis, and ultrasound would show you in ILD a thickened irregular pleura. See, this pleura is irregular, thickened, and you also see a few B lines beneath it. And on the left side also, you will see similar changes. The pleura, the left side is much more involved here. The pleura is moving very slowly. And this slow movement of the pleura is somewhat differentiating it from the COVID-induced changes. Can differentiate from COVID-induced changes. And sometimes in ILD, you will get a white lung behind this. So it sometimes becomes really difficult. And in such cases, you need to have a proper clinical history of the patient to differentiate it from COVID pneumonia. Another patient of interstitial lung fibrosis, a known patient, idiopathic patient. And here also you see a diffuse, the irregular pleura, thickened and irregular pleura with white lung. So now we come to COVID-19, and what are the findings in COVID patients? The earliest finding that we get is a subtle pleural thickening, slight pleural thickening. Minimal, but you can see just by eyeballing it, the pleura becomes irregular, fragmented, but the sliding is okay. The pleura slides well. Then you have in COVID patients small, when the disease process increases or advances, then you start seeing small, tiny subpleural consolidations. Then you have a bilateral patchy B lines, and the characteristic of these B lines is that you will see normal lung in between. This pair normal lungs in between, and very rarely you can have pleural effusion, very rare. Another important sign is called as light beam artifact, which was developed by Giovanni Valpicelli in 2020 in his famous paper, What's New in Lung Ultrasound During COVID Pandemic. And this light beam artifact is nothing but a coalescent B lines which come and go, which move with the respiration, and they don't stay continuously. And this off and on phenomena is classical for light beam artifact. And if you see this light beam artifact, it is somewhat much more specific for COVID. And you can diagnose COVID by these artifacts. Here are some examples of COVID patients. So this is a 30-year male patient who has actually been referred for ultrasound for right upper abdominal pain. He did have a history of fever 7 days back, but this fever settled by itself. And his X-ray done 2 days back, chest X-ray was normal. His abdominal ultrasound too was normal. So out of curiosity, I checked the lower lung, right lower lung, and I find that this pleura definitely is slightly thickened and irregular. And if I measured the pleura, it is slightly more than 2 millimeters. And this is, I think, this was a beginning of early COVID infection. And this is the same patient with a video clip here and slightly magnification. The pleura is definitely looking irregular, thickened. Without any doubt, you have a light beam-like artifact with thickened pleura. And I asked this patient to go for RT-PCR, and he came out positive. So ultrasound is very, very sensitive in picking up the patient in very early stages when chest is normal. Similarly, another patient, this is 27-year-old female with mild fever, and this is her X-ray chest, which is not showing in significant change except for some prominent markings here and some possibly elevated shadows, early shadows here, but nothing significant. And when I put my probe in, ultrasound probe in this area, I see this. So I have included 2 intercostal space here, and in the upper space, you can see the pleura is showing subtle thickening and this light beam sort of artifact. While in the lower intercostal space, you see a normal pleura, very clearly seen. And not only that, you see a beautiful A line. So this is classical appearance of the early COVID. It spares few areas, and there is subtle thickening of the pleura. Here also you can see the same slightly magnified view of this thickened pleura and this light beam artifact. So again, this patient came positive for RT-PCR, positive for COVID. So ultrasound really is very sensitive in picking up these cases. This is a known COVID patient who has been deteriorating continuously, and this is the picture of this COVID lung. Here you see this thickened pleura, irregular pleura. And here is that light beam artifact, this ground glass has beyond the pleura. This is very classical. And not only that, you see a tiny subpleural consolidation here, which will come just, you'll see it here. This is a tiny subpleural consolidation. So this patient has classical, all 3 findings which we see usually in a COVID patient. Now, this ultrasound can also be used to follow-up patients, as in this post-COVID lung changes. And this patient had recovered from the COVID, but his oxygen need was very high, and he was all continuously on oxygen support. And this patient was sent for a lung ultrasound, and these are the 6 zones on the right side. 6 zones on the right side, R1, R2, R3, R4, R5, R6. And when we see the right upper and mid lobe area, they look absolutely normal. We see normal A lines all over, the thin pleura, A lines here. But when we see the right lower zone area and the right lower lobe area, we see that their pleura is fragmented, slightly thickened, and there is a ground glass like haze or opacity beyond this pleura, define the pleura. So we know that the right lung is much more involved in the lower lobe area, and the upper and mid lobe area is spared. Let us see the picture on the left side. And on the left side, this everywhere I could see was this dense coalescent B lines, all over. So this patient, post-COVID patient, has a residual changes in the left lung all over it, in the right lower lobe, possibly of fibrotic-like changes, as Dr. Lina has just told us very beautifully. And also there is a small subpleural consolidation in this patient. So ultrasound can also be used for follow-up purposes to see whether the patient is improving or not, because if these B lines are changing towards A line, we can tell the treating physician that this patient in that particular area of the lung is improving. And we can follow up then, because continuous CT scan in a private setup is usually not possible. And this was the exercise of the same patient, which I was talking just now. And you can see this right lobe here is definitely involved. The upper part is spare on the right side, but on the left side, there's diffuse changes in this post-COVID lung. Possibly these represent post-COVID fibrotic residual changes in the lung. Well, before I end, I would show you a couple of articles that have occurred in the latest of this JUM journal. And this article is lung ultrasound imaging a worthwhile procedure for severe acute respiratory syndrome in COVID pneumonia. And it concludes that the lung ultrasound has good reliability compared to the CT chest. Similarly, there is one more paper, latest one, absolute, I think it is in this month only, which has compared the lung ultrasound with CT scan in COVID pneumonia. And it also tells us that the lung ultrasound is really very sensitive and it can detect lung injuries even before the CT scans show the changes. So I just wanted to share these papers with you to encourage all of you to start doing lung ultrasound if you are not doing already. And I think you would be definitely benefited. To close my talk, I would say that the lung ultrasound can be useful in patient management in ICU setup for mechanical ventilation purposes. We can also diagnose ventilator-associated pneumonias, and you can also assess diaphragmatic function in ICU setup by ultrasound. So to conclude, the lung ultrasound is less time consuming, can be used in bedside of the patient. It has a higher diagnostic accuracy than X-ray chest and even physical examination together. It can help in patient management, but most important of all, please remember always that to integrate this lung ultrasound finding with the history of the patient and physical examination and the lab results. I'm thankful to all of you for your kind attention. Thank you.
Thank you, Hemant sir.
Thank you.
That was a very thought-provoking talk. Anbarsu sir, yeah.
Yes, yes. Excellent, Dr. Hemant. I think you have opened a completely new dimension for many of us here in the audience.
Thank you.
Where we can actually use. I think there were a couple of our members actually asked that we don't know what is the role of ultrasound. I think it is very, very clear today that any radiologist who has been in a hospital setup, if they are asked to COVID ultrasound for chest, I think they shouldn't hesitate and go ahead and do it. Because once you start doing it, I think that experience will give them, at least they have got the foundation now where to start.
Yeah.
How long it takes actually to do the scan in a situation?
In a COVID patient?
Yes.
We have to do it very quickly, of course. And usually it takes around 5 minutes. 5 minutes. Yeah, 5 minutes it takes. Because you have to be careful not to get infected also.
Yes.
So yeah, that is the thing. And we do it during 5 minutes or like that.
Yes. And what happens if some patients have pleural effusions? And
well,
the lung interface goes away.
Yeah. So, if you have a pleural effusion alone, then it becomes okay. We have to use other clinical parameters to find out, because in clinical practice, COVID pneumonia would never present with a standalone effusion. But if you have a bigger consolidation, as I've shown you, then there is a possibility cause is bacterial and it may be non-COVID also.
Okay. And there's one more question in the chat box. Which sign is commonest in COVID you have come across, pleural thickening or light bulb sign?
No, both. We can see both together.
Okay.
Both are equally sensitive. They're extremely sensitive. Pleural thickening, and with that you can see light beam. I have invariably seen in all patients this light beam artifact.
So both are sort of occurring.
They come together. Yeah, they come together. And once you see this light beam artifact in subtle pleural thickening, you are 100% sure, especially in pandemic situation, that you are dealing with COVID infection.
Excellent. Excellent. Any other questions from audience? Because I think we
No,
have.
sir. I think that's it, sir. Yeah.
Okay, excellent.
Thank you very much. Thank you, sir.
Thank you, Dr. Hemant, on
Thank
behalf
you.
of TNPA, IRIA, and all its members and office bearers.
Thank you.
Sincerely, thank you for your contribution today.
Father, thank you.
Really an eye-opener, and thanks for your time.
Thank you.
So Venkata sir actually has a question. Hello.
Yes, I think so. Yes.
Ahmed sir. So he is saying that he faced difficulty with the visor in front of the face, and the clarity of the image is reduced. How do you overcome it? It's a very practical issue, sir. Yeah.
The face shield.
Yes, the face shield that we wear, it
Yeah.
actually reduces the clarity of the images. It fogs up. And is there anything specific that you do, sir? Because
Yeah, it does that. It does that. But then that is a part of our practice, and you have to adjust somehow to see the screen somehow. And
okay. So we thought we'll have some secret ingredient to get.
No, not like that. But basically, I took a slight more risk removing the face shield. Yeah, that was the thing. And of course, that is not advisable. And then I got COVID myself. But then that is a risk, definitely.
Sure.
Thank you, sir.
Okay.
Thank you, sir.
Thank you.
So
sir.
I think next is the basic anatomy by Dr. Anbar Sisa, sir. Please go.
Yes. I'll just go for sharing my screen.
Yes.
Can you see Murli?
Yes, sir. You can
Yes.
go ahead. Yeah.
Fine. Quickly, for the next 10 to 15 minutes, I just wanted to go to this MUCA reporting. What are the basics we need to understand in terms of CT and MR anatomy before we start reporting? We had some two wonderful speeches, lectures and teaching sessions by Dr. Dina and Dr. Hemant. And so that sort of covers many of the trends which are going on nowadays with the CT chest reporting in terms of COVID. Now we are going into the other trend, which is the MUCAR. I think there was a lot of people are asking, sir, we have to review the anatomy because there are a lot of things involved in this particular intricate area. So I thought I will just go through the anatomy, meaning I was just telling some of my fellows in my department that we have learned this intricate anatomy of head and neck about this pterygopalatine fossa, pterygomaxillary fissure, foramen rotundum, and all those things, and never thought that it is going to be used everyday practice. And this is one of the such times in the world in decades are that we are actually going to talk about those particular anatomical words almost every day, and that is very, very interesting. So the IRIA and ICRI guidelines has got everything you need to in terms of what you have to look at, and it was published in June 2nd. And just going through this anatomy here, just to take this sort of simple let me just get my arrow, sorry. Okay, so in the first image on your top left corner, I will just annotate. One second, I'll just get my arrow. Okay. So as you can see, this particular area, I'm just rounding it there. That is the area of superior orbital fissure. We are at the sort of skull base level at the anterior cranial fossa skull base. And the next image, when we come down, we come to a two important area where you will be able to you will be able to see this inferior orbital fissure. I'm just trying to see my arrow, which finding it a little hard. Okay, so this is the area where this line is ending, is the inferior orbital fissure going into the orbit, and this is the sort of the space which is seen posteriorly is your is this area. This particular arrow is your foramen rotundum going towards the cavernous sinus. And just come below this, the soft tissue windows, you will be able to see the same corresponding images, but you will be able to appreciate the superior orbital fissure and the pterygopalatine fossa inferiorly, and then the cavernous sinus, which is there on either side. And you can see this foramen rotundum is actually leading towards this cavernous sinus area, which is located there. And you can see the corresponding enhancement in the soft tissue windows. Going to the, we will come to that again in a moment. Just a second, bear with me.
Sir, you can use the arrow in the Zoom also.
Yeah, I'm just using the arrow, but it is not moving. It is just that. Just a second, just a second. Okay, okay. So now it's a little bit better. I'll just make it a little bit bigger. Okay, now we are able to see it. Okay, you're able to see it, Murli, now?
Yes, yes, sir.
Okay, okay. So I'll just go to the next slide here. Just to show
Sir, but you have not made it
bigger.
You want to share it like this, sir? Without.
Is it better?
Yeah, perfect.
So when I do this bigger, I'm not getting the arrow. That is why I was a little worried. I'm not able to show you that particular structure. That is why I said,
sir, there is an arrow in the Zoom app, which you can use. Is it seen in your screen?
In the Zoom app.
Once you make it full screen,
it's only a couple of slides, and then we will.
Okay, fine.
Anyway, so just to show you this image, which is the coronal CT scan image, we are looking at the maxillary sinuses. There are a couple of areas which you need to look at. One is this alveolar process of the maxilla, which actually forms the floor of both maxillary sinuses. So the two areas which you need to look at in the coronal images. The other one is the orbital fat. We can see that orbital fat is situated in this area. So I'll come back to this, so don't worry about it. So this particular area, I will just show you this. What are the checklist which is there in that particular article which has been published by IRIA, ICRA? We have divided into what are the things to look at in terms of PNS related, orbit related, and brain related. So in terms of PNS related, we should look at the nasal cavity. Things which we have to look for is like this mucosal thickening, septal ulceration, necrotic turbinate. We'll come to that in a moment when Bavaharan and the other Bavaharan will be talking on that. The paranasal sinuses, you will be looking at mucosal thickening, and then you will be looking at the soft tissue infiltration. I will show you what is the periantral fat planes in a moment, pterygopalatine fossa, infratemporal fat, and masticator space. And then the palate involvement is the hard palate, the mucosal involvement or bony involvement can occur there. And then the bony dehiscence or destruction involving hard palate. So these areas you will be looking at in relation to the paranasal sinuses. The next one will be the orbit related. You will be looking at the nasolacrimal duct and nasolacrimal sac. And you can see orbit involvement. We have to look at the extracornal fat, intracornal fat, look for subperiosteal collections, look at the ocular muscle, look at the orbital apex or globe involvement, and also optic nerve involvement. This will be using both CT and MR. This will be the same checklist. And brain related will be your vascular complications such as cavernous sinus thrombosis, carotid artery narrowing, thrombosis, or pseudoaneurysm, sometimes even subarachnoid hemorrhage. Other intracranial complications such as meningitis or meningeal thickening, intracranial granulomas, extraaxial or parenchymal collections, or infarcts or hemorrhage. So let me just go to sharing this DICOM images. So hopefully it works. And then we will go through. Okay, fine. Murli, people are able to, you're able to see this?
Yes, sir. Yes, sir.
Okay, fine. So this is an axial CT image. Okay, so I'm just going through each one by slices from the top. So this is what exactly I was talking about, the superior orbital fissure. That's one landmark which you need to see. That is the area where you will be seeing the orbital apex. Let's first go to the, in terms of sinuses, what are the things we need to look at? Okay, so when you come to the maxillary sinus, we are looking at, so posterior wall of the posterior lateral wall of the maxillary sinus can be thin, and sometimes you can have little dehiscence there. So that should not be mistaken for erosions. But look at the fat behind it. This is called the periantral fat plane, which is at the posterior aspect. And adjacent to this, you see the masticator space muscles. This is the temporalis muscle, and this is the lateral pterygoid muscle. And adjoining to these muscles, you are actually seeing the periantral fat plane. And these periantral fat plane are very important landmarks in the mucor reporting, because you will be seeing early infiltrations, increase in density of the fat, sometimes complete obliteration of the fat in these areas. And then if you go a little bit lower down, just below the orbital fat plane, you will start seeing this pre-maxillary fat planes you will be seeing there. And there is a little muscle, zygomaticus major, which is going along in this area from lateral to medial towards the angle of the mouth. And this particular area is just posterior to this, is your pre-maxillary fat plane. So in the same area, you will be able to appreciate the hard palate. The hard palate is here in the middle, bridging the maxilla on both sides. And going up a little bit, you will be again seeing this medial and lateral pterygoid plates. And then going up a little bit more, you will be coming to this particular area, which is the pterygopalatine fossa. I'm just zooming it a little bit. You'll be able to appreciate this pterygopalatine fossa here, which is a junction which, you know, most of the head and neck radiologists pride themselves in sort of knowing this area. So the periantral fat plane is actually adjacent to this masticator space muscles. So even sometimes you see masticator space muscle edema and abnormal signal in these areas. And this particular area is the pterygopalatine fossa, and this particular opening, which is sort of normally closed by mucous membrane, is the sphenopalatine foramen SPF. This is the pterygopalatine fossa. The lateral aspect of pterygopalatine fossa opens into the masticator space, and that particular area is called the pterygomaxillary fissure. So pterygomaxillary fissure, pterygopalatine fossa, sphenopalatine foramen. This is a junction because when you are in that particular area, you can actually see this little particular foramen, which is the foramen rotundum, which is going posteriorly, and this goes towards the cavernous sinus region, where the V2, the maxillary division of the trigeminal nerve, goes to these areas, goes to this particular place, and through the cavernous sinus, it actually reaches the petrous apex, where the Meckel's cave is located. So this particular area is the area of perineural spread of inflammation or tumor along the maxillary division of the trigeminal nerve. And at the same almost the same level, you go a little bit higher up, you will start seeing this pterygopalatine fossa is communicating with the orbit along the inferior orbital fissure, which is sort of here in this area. Let me just, this is the post-contrast scans. Just wanted to show you the enhancement of the cavernous sinuses on either side, as you can see here on either side. The cavernous sinus is seen there, and then just windowing a bit, we will be able to appreciate the differentiation of so we can see here, this is the foramen rotundum area, which is coming towards the cavernous sinus, which is enhancing here. This is the petrous apex region. When you go a little bit inferiorly, you will be actually seeing a little defect, which is on either side of the sphenoid sinus, which is your pterygoid canal or pterygoid plate. So the pterygoid canal is more slightly inferior and medial, while the foramen rotundum is slightly superior and lateral, but they both lead to this pterygopalatine fossa. So the intracranial communication is through the foramen rotundum, and also through the superior orbital fissure if it goes into the orbit. The skull-based communication is through the pterygoid canal, and the masticator space communication is through the pterygopalatine fossa and then the pterygomaxillary fissure. So we need to look at these areas. So first, once you look at the sinus and the periantral fat plane, the pterygopalatine fossa and pterygomaxillary fissure, then you go to the orbits. And once you go into the orbits, you can actually see the orbital infiltration. Just to zoom it a bit. Okay. So the orbit, you start seeing this medial aspect because the ethmoid sinus is here. It is the medial aspect here. We sometimes get subperiosteal collections or inflammation, and also from the maxillary sinus, it can involve the inferior aspect. So often medial and inferior aspect is commonly involved. Don't expect any bone erosions because there are tiny vessels which goes across these vessels, and the fungus can go along the perivascular plane and go into the other areas completely separated by the bone, and the bone destruction need not see in particularly in early cases. So obviously you look at the intracornal and extracornal fat, extraocular muscles, and then going towards the orbital apex. You will be able to see here, this is the optic canal which is going there. That's the superior orbital fissure. That's the inferior orbital fissure, which lead on to the pterygopalatine fossa in the coronal plane. And this is the just to see the bone windows in a moment. Here you will be able to appreciate this foramen rotundum here, which is located supero-lateral, and this is where it goes into the middle cranial fossa, to the cavernous sinus region, and medially at the level of just below that level, this is the area of pterygoid canal or the Vidian canal. Just going to the MR anatomy, which is needed to understand. Again, we'll be looking at the same thing. I'm just going to go through the CT T1 weighted image, which is, sorry, MR T1 weighted image, which is very, very useful. Okay, so one by one, I'm just going from the level of mandible. Some images are missing. Okay, so we are like looking at here the premaxillary fat planes. You can see that on either side. And this is the levator labiae superioris muscle, and this will be the zygomaticus major muscle on the lateral aspect. And you can see the periantral fat plane posteriorly in terms of we already discussed the masticator space, and this will lead on to the pterygopalatine fossa, which is normally filled with fat, as you can see here. And this particular pterygopalatine fossa, this is the lateral aspect, is the pterygomaxillary fissure. Medial aspect in relation to nasal cavity is the sphenopalatine foramen. And then going up a little bit higher above, you will start seeing the part of the superior orbital fissure, which is there, which also leads to the cavernous sinus. And then the foramen rotundum area is located somewhere in this area. It's a little bit thicker slices. There will be a few more images which we will be able to review. And we can see the cavernous carotid located there. And this is the cavernous sinus on either side. Always look at the lateral margin of the cavernous sinus, which will give a clue as to it is involved or not. And then, of course, the Meckel's cave fluid, the CSF signal in this area. So looking at the axial T2 fat sat images, again, we are going through the, so we can look at the images in terms of premaxillary plane, periantral plane. Obviously, you'll be looking at the mucosal thickening, inflammation, all those things inside. You'll be looking at the black terminated and post-contrast CT, but those are pathological. I'm just trying to show you the anatomy because pathology will be covered by both Sitaraman and Bhavakar in a moment. And when you go to the orbits, you can see that symmetrical appearance of the extraocular muscles, and the optic nerve is going towards the orbital apex. And obviously, you should look at the orbital apex area to look for any abnormalities. And the cavernous sinus is located here, where you will see in the internal carotid artery. And look at the caliber. Make sure that they are almost symmetrical and the flow wide signal is maintained. And on the coronal image, just to show you a little bit of anatomy here. And you can see the nasal septum and the turbinates and the maxillary sinuses. On the coronal image, there's one more important area which you need to show your attention, is to look at this floor of the maxillary sinus. You can see the fat which is located within the alveolar process of the maxilla. So sometimes when this is lost in your T1 weighted image, look at the T2 or stir image, where you will see some increase in signal. That means there is infiltration into the maxilla. we have shown in our article that sometimes CT may miss this infiltration or sometimes may show very subtle erosion or rarefaction of the bone in this area. So you need to pay attention to this area. And many of the time, these patients may be referred from your dental department or the oromaxillofacial surgeon saying there's some loosening of the teeth, some sinuses which are appearing, nodules which are appearing on the palate side. And we can actually see the hard palate which is located there and the mucosa surrounding the hard palate, which looks symmetrical. And so this is again a T2 weighted image showing the similar anatomy. So make sure you look at the orbits, you look at the sinuses, and you look at the related structures, the periantral fat plane, premaxillary fat plane, PMF and SPF areas. And then look at those foramina, which are through which there will be intracranial extension. Closely look at the cavernous sinus and the internal carotid arteries, and then look at the meninges in the same areas. When the frontal sinus is involved, then you look at obviously the disease may go directly into the brain at the frontal lobe as well. I think I will stop here. If I missed anything or if somebody wants a revision of this, I'm happy to sort of show those anatomy again. Murli, I think we can go ahead with the pathology by those two speakers, Bavaharan and Sitaraman, please.
Thank you, sir. I think that was a very elusive representation of the anatomy. May I now request Dr. Bavaharan to show us a few
Dr.
cases.
Dr. Sitaraman will actually.
Oh, Dr. Sitaraman first? Okay.
Yeah, hi. Can you hear me?
Yes, sir.
Yeah, I'll just share. Can you see the full screen?
Yes, sir.
Yeah, am I audible fully? Okay, good. Shall I go ahead?
Please go ahead, sir.
Yeah. Good evening, everybody. And in this small session, I'll be discussing with you a few cases from the clinical radiological perspective. And predominantly, I will be covering the orbital related complications as well as a few PNS cases. The rest of the cases will be dealt by Dr. Bhavagaran. Before going into the cases, and whenever we think of mucormycosis in radiology imaging, we usually have few cardinal features. That is actually 3 eyes. That is 3 cardinal features. First is infection, which is seen as a mucosal thickening and enhancement. Just a second. Yeah. Mucosal thickening and enhancement, as well as T2 hypointense content, which is seen as a in CT hyperdense contents. Okay. Then next, because of the angioinvasive nature of the mucor, we have ischemia because of the thrombosis formation, and this is seen as a necrosis of the soft tissue, which we in turn we see in imaging as a non-enhancing tissue, including the mucosa, soft tissue, as well as bones. So that is the second cardinal feature of the mucormycosis. And the third is the most important thing is the invasion. Because of this only, it is very rapidly spreading and it causes so much morbidity and mortality with its extension or invasion into the orbit and intracranial structures. So all the cases which I am going to show are COVID positive and mucor proven cases. And I will be concentrating predominantly on the orbital cases. So first case, this is a 45-year-old male patient with right-sided nasal block and tooth pain. As Anbarsus had said, it's a mild tooth pain on the right side and right side nasal block. This is the mild symptom the patient is having. And we have 3 images here. First one is the coronal CT. Second is the T2 fat sac coronal, and the third is the post-contrast T1. In the first image, what we see here is a complete opacification of the right ethmoid and maxillary sinuses. When we look specifically here, there is a subtle hyperdense content within, which is seen as a T2 hypointense content within the maxillary sinus and the OMC region, and the rest of the mucosa appears brightly hyperintense. In the post-contrast T1, what we see here is a normal enhancement of all the mucosa with non-enhancing central content, which is allowed, and this is a classic case of fungal sinusitis. But when we look casually at this one, we don't see much of the changes. But always look for the adjacent bones. Please look in this one. So when compared to the other maxillary alveolar process of maxilla, what we see here on the right side is abnormal increased signal intensity in the T2 fat set sequence. And it's again confirmed by the abnormal enhancement when compared to the left side. So this is a case of osteomyelitis. So this is a case of right maxillary and ethmoid fungal sinusitis with right maxillary osteomyelitis. The take-home point from this one is the contrast enhanced MRI is far superior to CT for evaluation of the early bone involvement, be it osteomyelitis or it could be osteonecrosis. Second case, this is a 48-year-old male patient with mild facial pain. We have 4 images here. One is coronal CT, second is T2 fat set coronal, then post contrast, and this is a subtraction image. In the CT, again we see bilateral, ethmoid, and maxillary sinusitis predominant or more on the left side. And when you look at the bones, maybe like it looks pretty normal here, and we don't see much of destruction or emphysematous changes in this case. We'll move on to the T2 fat set image. Here again, this says like the content appears to be T2 hyperintense and the mucosa appears to be bright. So it is a hyperintense content with a T2 hypointensity. So it is a fungal sinusitis, that is accepted. And here again, the mucosa is enhancing normally in most of the sinuses. But what is really important to look for is this one. If you see the maxillary process and the palate in this case, you see abnormal signal intensity is seen in both sides of the alveolar process maxilla as well as palate. But when you look in the post-contrast T1 image, what we see here is a differential enhancement on the right side as well as the left side. On the right side, there is increased abnormal enhancement. On the left side, you don't see it that much, like there is no abnormal increased enhancement, and which is very much amplified, or it is better seen in the subtracted image. Here, there is no enhancement at all on the left alveolar process maxilla as well as the palate, and on the right side, there is enhancement. So this is the difference which can be seen in the contrast enhanced MRI, and that's why it is the modality of choice for evaluation of early bone changes. So this is a case of bilateral sinusitis with osteomyelitis on the right side and osteonecrosis on the left side, and the CT is not helping in this case. So the take-home point from this case is the differentiation of osteomyelitis and bone necrosis is very important from the surgical planning perspective. I will tell you why. Because bone necrosis or any other soft tissue necrosis, the aim of the surgery is to get rid of it as much as possible. That is the concept for surgery from the bone necrosis, because the systemic amphotericin doesn't reach there, and moreover, in the necrotic tissue, the fungi grows pretty fast. And if you leave that behind, again, it will be growing and it will be extending predominantly. But in osteomyelitis, what they do is they just do decompression, or as much as possible, they debride that one and just leave. They don't remove every bone because it could be treated with the systemic amphotericin also. So if we map and give these details to the surgeon, so they will plan it accordingly. For example, if they want to do only FES or want to do anterior maxillary osteotomy, or it could be partial or complete mastectomy, palatal resection, everything, or whether they have to include other orofacial-maxillary surgeons also in this one. So all this pre-planning will go on depending upon the description and mapping for them. And any pre-planned, perfectly planned surgery is always better than an unplanned surgery and leaving behind some tissue, because this is really important in this case, since it is very, very aggressively extending and invading. We'll move on to the third case. It's a 54-year-old male patient with right-sided facial pain. We have 3 images here. This is CT coronal, T2 fat sac coronal, and T1 post-contrast coronal. So here again we see at the right-sided ethmoid and maxillary sinusitis. Apart from that, we don't have much information here, and maybe a little bit of asymmetry in the inferior rectus is seen in the right side. Coming to the T2 fat sac coronal, we have, when you see this area of mucosa, can you see, appreciate this hyperintense mucosa? This is normal mucosa, and here you have diffuse some sort of T2 hypointense mucosa is there. And when compared to the left side of middle turbinate and inferior turbinate here on the right side has become slightly hypointense when compared to the left side. And does this carry any importance? I will tell you in a moment. And in the post contrast, here you see there is extensive necrosis of all this mucosa turbinate on the right side, inferior as well as middle turbinate. This is the black turbinate sign, and here there is extensive necrosis of the mucosa and everything here. In addition to that, we have right orbital cellulitis predominantly in the medial and inferior aspect in the form of fat stranding. So this is a case of sinusitis with the right orbital cellulitis, necrosis of the mucosa and turbinates, that is T2 hypointense mucosa is there and black turbinate sign is there. Why I am stressing upon this T2 hypointense mucosa is that in case the patient, because quite a few patients what we are seeing are renal failure patients, we couldn't give contrast for the patient. In those scenario, if we have this one T2 hypointense mucosa significantly plus or minus diffusion restriction in the mucosa and not in the contents, so it may represent necrosis in a non-contrast MRI. So it may be helpful in those cases, and if at all you have a chance, always give contrast. That is the most sensitive as well as specific. But however, in non-contrast MRI, if there is no other way to give contrast, then please, we can use this one T2 hypointense mucosa as well as diffusion restriction of the mucosa as an indicator for necrosis of the mucosa as well as of the soft tissue. And we move on to the case 4. This is a 24-year-old male patient with left orbital pain. And this patient is a known case of CRF, and that's why we didn't give contrast for this patient. This is a coronal CT. First image, second image is a T1 coronal, and this one is a T2 fat cell coronal. What we see here is when you casually look, we may see it's a slight signal like a fat stranding is seen in the medial aspect of the left orbit. And we have left ethmoid sinusitis and the maxillary sinusitis here. But when you look into the T1, actually we should be able to pick up any fat stranding here. But obviously in this case, we don't see much of a fat stranding in this one, apart from mild bulkiness of the medial rectus and superior oblique muscle when compared to the right side. And this becomes the sequence of choice for this case, because this gives the exact extent of the inflammation of in the medial and the inframedial aspect with fat stranding as well as bulky nature of the medial and superior medial rectus and superior oblique muscles. So this is a classical case of left maxillary and ethmoid sinusitis with early left orbital cellulitis confined to the medial and inferior quadrant. Sometimes the maxillary sinus invasion can go into the inferior aspect. Ethmoid, as you are seeing here, it goes to the medial aspect, and from the frontal sinus goes to the superior aspect. So we have to be aware of from where it is extending from. Sometimes without any sinusitis, from the nasal itself, cavity itself, it can come along the nasolacrimal ducts to the inferior medial aspect. So take home point from this case is fat stranding and bulky extraocular muscles are the earliest signs of orbital invasion. It may go on to necrosis, abscess formation, and so on and so forth. We'll move on to the 5th case. It's a 35-year-old male patient with renal failure. This patient also with renal failure, that's why we couldn't give contrast for this patient. And the patient is complaining with left orbital pain, proptosis, and blurring of vision. Whenever the patient is presenting with blurring of vision, always we have to be alert and look for specific signs. In this case, what we have 3 images like T2 fat cell coronal, and this is a diffusion weighted imaging, and this is a T2 fat cell axial. What we see here is a bilateral ethmoid and maxillary sinusitis more on the left side, and we have patchy areas of T2 hypointense mucosa in this region. And what we see here in the orbit is an extensive orbital cellulitis involving intraconal, extraconal compartments all around, and it is extensive. And one more important thing you see here is this one. So this is a collection which shows diffusion restriction here, and this is a case of extensive orbital cellulitis with abscess formation. Because without contrast, there are 2 possibilities for T2 hyperintense areas. It could be a necrosis or it could be abscess formation. So this case with the diffusion restriction is an abscess formation, and this becomes an emergency for the orbital surgeons because it increases the intraorbital pressure, creating orbital compartment syndrome. Just a second. In this image, this image is not going. So in this image, what we see here is a contour of the eyeball. On the right side, you see normal contour. On the left side, what we see here is a abnormal contour with the posterior tinting of the globe, and we have significant proptosis. So this is a classical sign of guitar pick sign. You can see the shape of this guitar pick sign as well as this one. So this is a classical case of orbital compartment syndrome secondary to extensive orbital cellulitis and abscess formation in the left orbit. So take home point from this case is always look for proptosis and deformed globe in any case of orbital cellulitis, because this needs emergency decompression of the orbit to save the vision. Otherwise, whenever there is a gross increase in intra-orbital pressure, it will go for stretching of the perioptic nerve sheath complex and causes ischemic optic neuropathy and permanent loss of vision. So we have to be alert and we have to inform the clinician regarding this one, and they have to take up for emergency orbital decompression. So case 6 is a 60-year-old male patient with the right retroorbital pain and incomplete third nerve palsy. This patient presented with the pupil involving incomplete third nerve palsy. So we have 3 images: T2 fat cell coronal, T2 fat cell axial, and post contrast T1. So in this one, what we see here is a mild sphenoid sinusitis on both sides. And in this image, what we see here is a asymmetrical thickening, soft tissue thickening in the right cavernous sinus and orbital apex region, and which is again demonstrated with the abnormal enhancement of the soft tissue and thickening and enhancement in the anterior aspect of the cavernous sinus and the orbital apex region, which in turn is causing oculomotor nerve palsy. And this is a case of sphenoid sinusitis with right orbital apex involvement causing third nerve palsy. Even though the most common involvement of the sinuses are ethmoid and maxillary sinuses, sometimes we do see cases from sphenoid as well as the frontal sinuses causing complication and invasion to the adjacent structure. Here in this orbital apex region, it could be from the sphenoid sinus directly, or it could, the inflammation could come from inferior aspect along the pterygopalatine fossa and orbital fissures. So take home point from this case is indirect involvement of orbit can be due to inflammation in the orbital apex and cavernous sinus region. We have to be aware and we have to look for in case of orbital pain, retroorbital pain. Case 7, we have a 55-year-old male patient with right orbital pain and acute vision loss. So in this case, we have 3 images again: T2 fat cell axial, the diffusion weighted imaging, and this is MRI. In this first image, what we see is extensive right orbital cellulitis with thickening of the extraocular muscles and fat stranding, and even small abscess formation here in the anterior aspect. And what more interesting is in this one, if you look carefully in the optic nerve region, here you can see a short segment of diffusion restriction in the optic nerve in the intracorneal compartment. Here on the left side, it is not seen. And in the MRA, what we see here is a normal left ophthalmic artery. On the right side, we don't see that. So this is a classical case of sinusitis with right orbital cellulitis as well as right ischemic optic neuropathy secondary to the occlusion of right ophthalmic artery due to the fungal invasion. So take home point from this case is always look for ischemic optic neuropathy changes in patients with acute vision loss, be it a diffusion restriction in the optic nerve or occlusion or non-visualization of the ophthalmic artery in MRI sequence. We'll move on to the case 8. This is a 65-year-old male patient with severe headache and orbital pain. What we have are 3 images: T2 fat cell coronal, post-contrast T1 coronal, and T2 fat cell axial. In this one, again, we have extensive sinusitis on both sides with, you can see the T2 hypointense area extensively on both sides, which is again showing non-enhancement of the mucosa, turbinates, almost everything is gone here. Nasal septum, everything is gone except a small part of the left inferior turbinate. And you can see the orbital cellulitis also on both sides, more on the right side. And one more thing you have to appreciate is this one. You can see in T2 fat cell coronal, abnormal signal intensity is seen in the basifrontal lobes. And here it is not showing much enhancement except a marginal mild enhancement in this region. So this means it is necrosis is seen on both sides of the cribriform plate. And one more important point I just want to tell you in this juncture is this one. Any thin bone, for example, a lamina or cribriform plate, you can't have, you don't have a specific signs for necrosis. So whenever you see a necrosis on both sides of these bones, then please take it as a sign or a point of necrosis of that bone, because in CT it may be still seen without much destruction. Why it is really important means, if you mention that the bone is necrosed there, they will be relatively little bit more careful. Otherwise, no, if they touch this one, it will go up and it just enter into the intracranial region, causing CS of rhinorrhea and so more many complications. So in this case, we have to be alert and we have to tell them there is a possible chance of ischemic necrosis of the bone also in this region. And in this case, again, one more feature is the abnormal contour of the eyeball, which is having a Guitar-Pick sign again. And this is a case of orbital compartment syndrome on the right side. So, and one more important thing is that whenever the immunity of the patient reduces much more, we have a bilateral extensive acute invasive fungal sinusitis on both sides and invading from all the sinuses. Because till now what we have seen is predominantly on the one side, either on the right side or left side. Here it is much more. So the immunity should be much less in this patient. And this is a classical case of rhino-orbito-cerebral and mucormycosis. So take home point from this case is always look for intracranial invasion and alert the clinician for early intervention, because early intervention may reduce the mortality rate for these patients. Then the last case is 30-year-old female patient with right side facial pain, ophthalmoplegia, and acute onset of severe headache. So this is a T2 facetaxial image in the orbital apex region, and this one is the pterygopalatine fossa region, slightly inferior, and this is a post-contrast image. So what we see here is a abnormal soft tissue thickening with the increased signal intensity on the right side when compared to the left side. This is the cavernous sinus region, and here we have extensive infection and inflammation in the pterygopalatine fossa, masticator space as in the posterior retroantral region and extending all the way superiorly. And here we have abnormal enhancement, asymmetrical soft tissue thickening and enhancement in the cavernous sinus. So this is spread from the maxillary sinus along the pterygopalatine fossa and superior orbital fissure and to the cavernous sinus in this region. But we could explain the reason for the ophthalmoplegia due to cavernous sinus involvement in this case. But how could we explain the cause for acute headache, onset headache? Here, in addition to all the findings, what we can see here is a well-defined round lesion with a T2 hypointense wall. And what we see here is a nice enhancement within that. So this is a case of myocardic aneurysm arising from the superior cerebral artery, which is secondary to all the inflammation or infection extending all the way to the cavernous sinus and along the trigeminal nerve to the prepontine region. So this is blood, and this is the cause for acute onset of headache for this patient. So this is a case of sinusitis with extension to these areas with the right SCA myocardic aneurysm, and more important thing is that there is no orbital cellulitis. This is indirect involvement of the orbit producing ophthalmoplegia. So the take-home point from this one is always look for signs of vascular involvement like vasculitis, thrombosis, or aneurysm formation. So these are the radiology red flags regarding orbital involvement. First is foremost is the orbital fat stranding and bulky intraocular muscles. Then look for proptosis and abnormal growth morphology to evaluate for orbital compartment syndrome. Then look for the inflammation in the orbital apex and orbital fissure. Then SO, superior ophthalmic vein and cavernous sinus involvement. And sometimes with acute vision loss, we have diffusion restriction optic nerve, which is forming ischemic optic neuropathy and bone erosion and destruction of orbital walls in CT. Thank you.
Thank you very much, Sitaraman. That was a fantastic talk, and it sort of covered most important aspects of sinus and orbital imaging in mucormycosis. I think, Murli, I think we can go ahead with the next talk by Dr. Bavaharan. I think that will give the completion to this talk so that all the other sort of the complement related areas to this talk will be covered by Bavaharan. There will be some overlap which we deliberately actually planned. Bavaharan, please go ahead.
There were a few questions in the chat. You want to take it?
This is something.
Yeah, I think you have answered most of them, Anbar sir.
Yeah, it's already answered, I think. I think
Yeah,
let's
yeah,
go
sure.
ahead. Talk and then we'll answer them together.
Sure, right.
Am I audible now?
Yeah, yes, you're audible.
So good evening, everyone. Good evening, everyone. I think the most of the basic and the important concept of the black turbinate sign, the T2 hypointensity, how does the mucor look, what are the anatomical regions to look for, and also to evaluate the orbital and the baseline intracranial evaluation has been covered already. So the predominant point is that most of the surgeons, the ENT surgeons or the dental surgeons and the orbital surgeons, they are more comfortable looking at the coronal images, and the predominant talk will be on the coronal image because they are more used to seeing the coronal images. And as from the radiologist point of view, we need to look at all the aspects, both the axial and the coronal images, to look into the subtleties of this mucor, because the point of stopping of surgery in cases of mild, moderate, and severe mucors are that they have to see a normal bleeding plane where they can actually stop the surgery. So that is very important, and we need to evaluate all the necrotic foci which has been evaluated. Is it osteomyelitis or is it osteonecrosis? These two are very, very important because the treatment is absolutely very variable. If there is osteonecrosis, that part of the bone has to be removed. Whereas in osteomyelitis, that part can be debrided and the antifungals will work. Right. These are all being covered, and these are very subtle cases of mucor which is sitting in the sphenoid sinus. Again, the most common areas, as already been described, are the ethmoid maxillary and the turbinates. But sometimes you need to look into the close area. This was a chance pickup, which was a patient having an acute headache, COVID-treated patient, and we evaluated it. And when we are doing MR of the brain, we picked up this particular lesion. This was just treated with antifungals. And this the case which has been already described, just going through quickly. There'll be about 15-20 cases which I'm going to discuss with you very, very quickly. And here it is, the black turbinate, that you can see the hypointense T2 hypointensity, which is getting from the OMU into the middle turbinate. Right. So these are all has been described, and this is one more thing which is which can happen with mucor. Now, you don't see much of a mucosal thickening here, but you can see subtle the mucosal thickening and the T2 hypointensity, and you could see in post contrast there's not much enhancement. But here you could see this mucors also have the capability of not growing big, rather than getting subtly walking on the walls of the floor of the orbit, thereby eroding it and causing inflammation of the inferior orbital compartment. So again, there's a premaxillary, and lateral to that, there is also inflammatory changes. Now, these are very subtle findings that can be seen with mucors. Right. So here we thought, okay, we have ended with having sinusitis here. There is a T2 hypointensity in the inferior turbinate here, both the inferior turbinates, and this is the middle turbinate, which is again showing non-enhancement. And you could see the ethmoid, which shows non-enhancement of T2 hypointensity, which was seen, okay, we thought we have ended here. But suddenly, out in the contrast, you could see there was another focus, which is enhancing, which was, it's about 35-year-old male. Again, COVID recovered, but absolutely no comorbidities in this patient. Not a diabetic. The ferritin level was absolutely normal throughout the COVID period. He had very mild COVID, not requiring oxygen, nothing. But this patient developed a mucor here, and we could see there is a cerebral abscess that is developing in the distal period. Now, these are also very important. So from the radiologist point of view, even if there's going to be a PNS requisition that comes to you, do a brain evaluation while doing at least the contrast, or at least do a diffusion. In my center, it has been a practical thing that whenever a PNS is asked for mucor, and if we find a mucor and diagnose a mucor, a mandatory diffusion and a FLAIR image of the brain will be there, and in the contrast, the brain will be compulsorily included with a that is the head and neck array coil. It's a large coil, but actually in a 16 or 32 channel unit, this is possible with them. And so always include the brain in your studies. That is important. Right. So again, this is a case where you could see that there is a T2 hypointensity. Look at it, the predominant sphenoid sinus and the posterior ethmoid involvement. Now, these sort of things always goes behind. You could see here that this is the retromaxillary region, the pterygomaxillary region, where you could see the abscess formation. Now, when you have this kind of an imaging, or when you have a problem in the pterygomaxillary fissure or pterygoid space, it is important that you go very, very thin to evaluate for neurovascular involvement getting into the brain, right? So this is another case. This was a patient, a 55-year-old diabetic female. Biopsy was done, an SL endoscopy was done. The biopsy was done from here and proved to be mucor. You could see there is not much of mucosal thickening here, but you could see here there is definite mucosal thickening and T2 hypointensity sitting. But predominantly this patient had premaxillary involvement. See, this premaxillary involvement, you could see here, that is the premaxillary involvement, which is going extensively necrosed tissue, which is in front of the maxilla. And you could see extensive fat stranding within the orbit. So these kind of imaging is also possible where the extra sinus involvement is a proposition with the mucor imaging, right? Now, here you could see again the involvement of the right maxillary sinus here, and you could see the inflammation going on around it. Now, all inflammation need not be direct fungal invasion. Remember that. So this is because whenever there is a fungal sinusitis of the maxillary or ethmoid sinus, there is always a perisinus inflammatory change, which is classical of fungus with T2 hypointensities. So these regions are not always direct invasion, but there can be inflammatory changes, right? Again, this case was actually went in for a follow-up the next day because the patient swelling was so much increasing. They were planning for surgery, but the patient refused the surgery on day 1. And the second day admission, the patient went in for severe swelling and respiratory difficulty. So a tube was put in, and you could see here the patient was shifted to see if there is any significant involvement where they have to operate now. Now, this is only about 36 hours before the previous imaging, but you could see the extensive involvement which has gone into the pterygoid space, into the premaxillary space, and everywhere that it is gone. Right. So here you could see that is the premaxillary space involvement. Here you could see the pterygomaxillary fissure. So that's the pterygomaxillary fissure, and this is the pterygoid space which is involved. The retromaxillary orbital fat is lost on both sides, and there is inflammatory changes. So this is another case. We thought, okay, everything was simple, not much of orbital sinus involvement, but you could see that T2 hypointense regions, which is seen only in the frontal sinus. Now, this was very rare. This patient presented with classical left-sided headache. He had left frontal headache. We did that, and when we did close sections, we could see that there is something here sitting in front in the frontal region. Now, this, again, when we went ahead up to the brain, we found another abscess sitting there. Now, this is very important when you do a PNS imaging, because there is always a subtlety that you may miss a brain involvement, which is a small abscess formation like these two. Here you could see the sinuses are absolutely normal, the turbinates are normal, but you could see only the frontal sinus, only the left frontal sinus is involved, and there is a cerebral abscess. So the brain imaging comes to the rescue here. It is very, very important. You could see here again that lesion showing a diffusion restriction here, and that showing a peripheral enhancement here. So these are very, very important. This lesion is showing the peripheral enhancement here. And you could see that. So again, as Dr. Sitaraman pointed out, in all these cases, there need not be essentially a bone erosion that can be picked up by CT. Remember that. So there can be a distal aneurysm. This can be a completely a new variant, but it's very important to pick up these lesions in the imaging. Now, This is the case that we were all talking about, picking up the early alveolar space involvement. You could see the maxillary sinus is involved, and you could see there is a premaxillary space involvement here, and you could see the abnormal signal intensity in the alveolar process. Now, again, this is an osteonecrosis which is sitting over the alveolar process. So this is another case. You could see that the right maxillary, ethmoid, and the inferior turbinate, the middle turbinate is involved. You could see the black turbinate sign here, and you also see the inflammation of the medial. That you could see that is the medial rectus, that's the superior oblique muscle, and the inferior rectus, which is all inflamed. What struck me in this case when we had the first imaging was this particular thing. So you could see here, what is this? That is the superior ophthalmic vein. Now, in here, you could see the superior ophthalmic vein is not visualized, but here the superior ophthalmic vein is visualized. So it means it is definitely dilated and it's hyperintense. And this was a incidental cyst there, sitting arachnoid cyst. So we went ahead and evaluated the pterygomaxillary region or the infratemporal fossa. You could see here that there is definitely an inflammatory mass sitting over in the pterygomaxillary space. Here it is absolutely normal, and this is the pterygoid fossa where it is completely inflamed and there is a mass lesion sitting here. There is a soft tissue definitely sitting here, and it is going through and entering into the cavernous sinus. So that non-enhancing region here is the cavernous, which is there, the early enhancement with necrosis of the pterygoid plate here, and there is a involvement of the cavernous end. This, if had been missed, this patient would have actually gone in for extensive inflammation, and they can go into progression of this particular disease. Here again, you could see that zoomed up image, which shows the soft tissue. It's a very, very subtle soft tissue in the inferior quadrant of the cavernous sinus. Here it's absolutely normal. And when you do a T2 imaging, now if you take a thin sections, you could find that particular lesion. Now, these are very subtle things which needs to be picked up when doing this particular imaging, because this is a monster. What we are dealing with, Mucor, is absolutely a monster. If we leave a good component or a small component inside the brain, that can lead to devastating complications. Again, another case where you could see there is extensive inflammation of the cavernous sinus, and you could see the left common carotid internal carotid artery, which is completely narrowed in this case. Okay, we did a diffusion for that. You could see here that there is a lesion sitting here. There's another case where we thought there is something sitting over in the medial aspect of the temporal lobe on the right side. So this was picked up with diffusion. Now, if a direct PNS imaging was done without doing a diffusion, there is always a chance that these particular lesions in the intracerebral components can be missed in this case. So diffusion sequencing of the brain is very, very, very important to pick up small abscess and early inflammation of that particular region close to the base of skull. And when we did a contrast, you could see here that's a soft tissue which was sitting here, and here you could see that the entire temporal bone base is actually eroded here. So you don't know whether it is foramen rotundum or mobile, but it is eroded, and there is edema sitting over the medial temporal lobe. And this is a T2 weighted image which shows the soft tissue component in the medial temporal lobe. So these are all small subtle things which needs to be evaluated. Again, a diffusion weighted image where you could see the diffusion restriction in the right frontal lobe. Again, this was as similar to one of the cases what shown by Dr. Sitaraman. So you could see here that the bilateral ethmoids are involved, middle turbinates are involved, and you could see that it is extending into the brain to the right side. So you could see here that this part of the brain is completely involved, and that is because of the erosion of the cribriform plate here, and it's going into the brain. That is a direct fungal invasion to the brain. You could see here the orbits are absolutely normal. The patient presented only with headache here. Right. This was a case. We thought initially when we did a case, okay, there is definitely the sphenoid middle, the inferior turbinate, and you could see the sphenoid recess is involved, and you could see here the sphenoid showing a T2 hypointensity. So we thought, fine, this is a very direct case. The patient had only a left-sided pain here, so no other symptoms. So we thought we ended here. But there was something which was striking here when we did a contrast. You could see here that there is an abscess sitting exactly in the pterygomaxillary region. So you could see here, that's the pterygoid abscess. You could see here there. Now, when you take a closer look through the foramen rotundum, it is extending into, you could see here through the, along the way, this is a classic perineural spread of these lesions. And you could see that the abscess is sitting here. These are two abscesses which is entering into the brain by perineural invasion. Now, these has to be, once they have actually removed it, they have to decongest or actually go puncture this particular region and aspirate so that they decompress it. So remove the abscess at least, or if they are not able to get into the brain, at least for the surgery aspect. So these are very, very subtle findings which we need to evaluate. This is very gross. The patient presented semi-conscious, was completely not cooperative for MR, but we had to do an MR. You could see a huge infarct sitting in bilateral frontal lobes. So again, very subtle. You could see the orbits are normal in this case. Not all mucous actually spread by a specific 1, 2, 3, 4 route. It can spread anywhere. It can spread into the orbit. It can spread into the premaxillary space. It can go into the retromaxillary region through the pterygomaxillary fissure. From there, it can enter the brain. It can, from once it goes behind it, through the V2, it can take the base of the skull or the sphenoid through the sphenoid bone, foramen ovale and rotundum. It can enter the brain. That is one way of entering the brain. The other way of entering the brain is through the pterygomaxillary fissure, through the superior orbital fissure. It can enter. That is 2. Number 3 is direct invasion. So it can directly invade the brain from the anterior skull base. So you could see here extensive necrosis here, and there is, we don't know whether how much of infarct and how much of actual component of fungus is there. When we did the MR angiogram, you could see the right, the A1 segment and the entire right ACA is not visualized. That's a complete occlusion because of the vascular invasion. The entire A1 segment is completely thrombosed in this case. It's completely occluded, and this patient did not survive. This patient did not survive. Right, this is another case, again, of the sphenoid sinusitis. You could see the small infarcts here. Patient presented with the left-sided hemiplegia, where you could see the left ICA is completely gone. This is another case, right? See here, you could see again, sphenoid involvement, T2 hypointensity, maxillary involvement, yes. There is orbital cellulitis, fine. Sorry for this. And you could see when we did an angiogram and we did T2 itself, we found the right ICA was smaller than the left ICA. So it means the soft tissue is entering through the superior orbital fissure into the cavernous sinus. When we did angiogram, you could see the supraclinoid part and the petrous part, which is actually narrowed, and you could see the mycotic aneurysm of the M1 of this particular case. So this is a very rare one, but this is because of the chronic, because of the inflammation that can lead to acute aneurysms. Right, this is another case where you could see that ethmoid is involved. You could see the extensive pre-maxillary space involvement, the maxillary space involvement. But what struck us was something here. It was there. It was there. That is where actually through the rotundum, the V2 nerve enters. When we did a diffusion, we could find that particular lesion was there, diffusion restricting. We could also find a diffusion restriction in the pons close to that. Now, this patient, actually a COVID recovered patient, came with semi-conscious state, but the 2 days prior to the semi-conscious state, he said that he had a sensory loss, sensorineural loss on the left side. He is not able to feel the sensation on the left side of the face. This was his complaint. This was registered. So when we did, we found that this particular lesion was actually entering through the V2, and it was catching the V2 and going up to the trigeminal root. This is a classical example of perineural invasion. Dr. Sitaraman showed you a case where there was through the orbital apex, it can enter into the angle, that is the cisterns. This is one way of entering into the cisterns. The other way of entering the cisterns is by V2 route. So these are the two routes through which this mucor can enter anywhere into the brain. This is again a post-operative case. Again, there are a few post-operative cases. There is a lot of questions from the surgeons when to do post-operative imaging. Now, this is absolutely a tricky question, very, very difficult sometimes, because surgeon wants to discharge those patients based on MR imaging. Now, sometimes the problem is that in the early imaging, the blood products cannot be very, there can be blood products in about 3-4 days that can lead to crustings. Now, this crustings can actually cover the fungus if there is going to be an underlying residual fungus. That's going to be very, very tricky. So we do scans only if there's going to be a complications post-surgery, or if there's going to be a problem or a pain when the patient complains. Now, this is a case which I showed you earlier. There's an abscess, there's a post-operative case of that same patient. You could see here, they have gone into the brain, they've removed it, and they've packed the abscess cavity here. They've actually partially drained it. But still, in this case, the ICA was narrowed, and you could see the soft tissue is actually growing in the cavernous end. This was after 1 week post-surgical. And you could see this is the fat, which is they have taken in and plugged it into the base of skull in order to prevent the leaking of CSF or the herniation of brain. But here you could see the definite soft tissue there sitting in front of it. This patient also had a residual abscess there, and this patient developed a hemorrhagic infarct in the posterior, the temporal lobe, post-parietal lobe. So this was a parietal infarct with hemorrhage. This was absolutely post-surgical, but this was 1 week later. So most likely this particular residual fungal infection has invaded the ICA and then causing thrombosis or vasculitis of this particular ICA, and that leading to infarcts in the later stages. There's another case where they've gone in and extensively removed the skull into it. You could see here, even in the diffusion, that there is a proptosis here and there is an orbital wall involvement here. But here there is an obvious large infarct sitting in the brain. This is again a post-operative case where the patient presented with left-sided palsy. Now, there's another case where the patient underwent an extensive surgery twice, and the patient developed pain on the left and right side of the face in the maxillary region. So when we did an MR, we found out that there is definitely a premaxillary, and they could see here is involved. And as discussed, is the alveolar surface, which is involved on both sides. You could see that is the root of the first molar tooth, which is involved. The third molar on the left side is involved. See, these are all findings where we can actually say there is definitely a direct invasion of this fungus and osteomyelitis of this particular bone. Again, you could see that there is definite involvement here in the alveolar surface, which is involving the first, second, and the third molar tooths. So this patient had to undergo an extensive surgery, but actually the debridement was done because on both sides it was seen it was very difficult to remove. So they underwent an debridement, and the patient is doing well with amphotericin. This is another case. Again, I told you about the difficulty in post-operative imaging. You could see again a T2 hypointensity here. If you give contrast, again, it is not going to enhance. It's an extensive surgery done on both sides. And T1 also doesn't show much except for subtle hyperintensity here, not much. We couldn't actually conclude because the patient was absolutely normal. Oh, we thought this could be a post-operative change, just go and do a biopsy. And then they went in and actually they saw extensive blood clots, crustings here because of the post-operative changes. The blood comes and crusts over the mucosal thickening. So they actually removed it and the patient did not have any recurrence. So these are some of the subtle findings which has to be looked for. Though the major findings are very obvious, there's orbital involvement, the premaxillary involvement are quite obvious. But when you do a contrast, make sure that you always do it in thin sections, if possible in 3D contrast imaging. Remember to include the brain in your studies in the contrast, or at least the diffusion and the flare images. So these are all very, very important. And always evaluate the cavernous sinus and always evaluate the cisterns. There are two ways, as I told you, through the perineural spread and perivascular spread, and that can lead to thrombosis of the vessels. And thrombosis can be anywhere. There can be mycotic aneurysms, thrombosis anywhere. It can involve the ophthalmic artery. It can involve the MCA, ACA, ICA, anywhere. Even if you have it, always in T2. It is easy to see the T2 sections. In T2 sections on axial, make sure both the ICAs are symmetrical. If there is asymmetry of the ICA that indicate that there could be a soft tissue there sitting, have a closer look at it. And when you give contrast, make sure you evaluate that particular region also very, very closely. Thank you.
Thank you, sir. I think we just have a few questions in the chat box, which I think you've already answered. Yeah. How to differentiate reactive inflammation from actual organism invasion?
Sorry, yes, see, it's again, this is a, on MR, it is actually a very difficult thing again. Whenever there is an inflammation, there is going to be a deep hyperintention. But when you're going to see a mass, when you're going to see a soft tissue mass there sitting in the retromaxillary fissure or the retromaxillary region with loss of orbital. Now, or loss of orbital plane is a common finding when you have even the inflammation, or if the tumor is going, or the lesion is going to spread through the pterygomaxillary fissure. So if there's going to be a direct widening of the pterygomaxillary fissure and with the soft tissue component there, it is a sign of direct invasion through the foramen.
Just to add to that point, Bavaharan, sometimes it is difficult. It is not possible to differentiate where the organism stops and the inflammation happens. We tend to assume that the inflammation is at the border of the organism. The enhancement means that there is inflammation, and there is a central non-enhancing area means that there is fungus. That is the sort of concept which we are using. But most of the time, as Bavaharan already told the audience early on, when they do surgery, they look at where it bleeds. So the bleeding area is the area where there is a margin of surgery. It is not necessarily belong to what we see on our scan. So, that is the area. Wherever there is a vascular invasion, there is no bleeding. So they will keep on cutting into the area where it starts bleeding, that probably they will think that is the invasion. So when there is a blood flow, even if there is a fungus, not a problem, because they will be treated with antifungal antibiotics, and hopefully that will recover. That is the sort of general concept.
Yeah, it is actually the same. That I showed you one of the brain images where you found the lesion was there picked up on T2, but on contrast, you could see a non-contrast enhancing. Actually, it doesn't enhance with contrast in those lesions. So these are all subtleties that we need to look into and tell the surgeon actually where actually you see the inflammation ends. So they can go in and do it that particular area. And if they see a bleeding earlier and a normal tissue there, viable tissue there, they generally stop there, because as Dr. Anbarus has pointed out, the blood flow is good there, so the antifungals reach to that particular region.
The second one is, of course, when to do a post-operative scan and how to differentiate.
That's an absolute tricky question, and we tried doing it fourth day. Some surgeons wants to do it at fourth day. We tried 1 or 2 cases, and there was a lot of bias in those cases because they feel like they have removed it, and we give that as a T2 hypointensity, go and reevaluate. Then that becomes the puzzle there. So what we have done now is we are waiting for about 2 weeks at least before we do a repeat imaging, or if the patient has this, one of the cases which I showed you was operated elsewhere and the patient developed a loss of vision on day 2 of surgery. Day 2 of surgery, the patient developed loss of vision. Now the question was whether it was a post-operative complication or is it a fungal invasion. So in that case, we had to bring that patient back, and we found out the cavernous sinus was involved and the ophthalmic artery was occluded, and we said this is a direct fungal invasion which has actually happened post-surgical.
I think one thing which we need to remember is that this is fast spreading. Meaning yesterday evening, somebody may have sinus disease. Today morning, they may have orbital disease. And today evening, they may have brain disease. So it's very important that, whatever you do it quite fast, and you convey you cannot wait for like 1 day for reporting your scans in this particular situation. You have to convey to the clinician as soon as possible on the phone, tell them that this is what you are thinking, and the patient, if the patient need to have surgery, and they will have to do it very fast, because during the surgery, if it is even delayed for 24 hours, there will be more extensive disease. So that's one important concept we need to understand. So don't delay your reporting for these patients. We will have to treat it as an emergency.
Yeah, 35-year-old who had mild pain on the right side on day 1. That's on 15th day of COVID. Next day, actually, the patient was supposed to come for an MR because he had some eye pain. Afternoon 1:30, he lost his vision. So it's about it's about hardly some less than 20 hours where he lost his vision and came for an MR. We picked up, there was extensive inflammation of the orbit entering into the brain and complete excentration was done. So 39-year-old guy, absolutely devastating to see the post-operative imaging.
Yeah, absolutely. Absolutely. I think this is a phenomenal session. I think congratulations to all the faculty members, Lena, Dr. Hemant,
Thank you all.
Thank you, sir. Sitaraman and Bavaharan. Because, I was just observing the number of participants. It sort of reached around 150, 160, and it just stayed 150, 160, what we call them as concurrent users. Throughout the session, nobody has left the session, meaning just once Bavaharan finished, about 50 of them left, but everybody stayed till the last slide. And that is a phenomenon of any online meeting, because most of the online meeting people start and then they drift off and sort of go away. And I think this is something which we have really given something for the audience to think and clarified many of the doubts. Okay, there is one more question. This general question, like, does steroid help? Steroid help in what? Is it probably Mucor? Does steroid help in Mucor? Bavaharan?
Steroid helps to helps the Mucor to spread more, sir. Probably.
Yeah.
Actually,
it helps Mucor, but doesn't help the patient. Okay.
Yeah, actually, that is one of the way of like that is the thing which increases the hyperglycemia, so that it forms a medium for that. Actually, so
Yes.
in fact, like it is one of the combinating factors, multifactorial thing.
There's one last question. How do you differentiate hemorrhage from the residual fungal sinusitis? When is the ideal time to do it, particularly in post-op? I think you said the 2 weeks, isn't it right?
Yes, sir. Yes. And now we have started to do the 2 weeks. Now the question is, even there's going to be any crustings or residual hemorrhage, actually it tends to resolve by about 7 to 10 days. That's what the surgeon says. But generally, 14 days is ideal actually if you want to repeat the MR to see the clearance if there's going to be. But
Yes.
see, repeat imaging, logically speaking, you need to do to a patient actually who has developed or new symptoms or any pain or not recovering from the previous pain to look for any other findings. But
Yes.
There are a few patients who demand repeat imaging. They're demanding actually. They're demanding repeat imaging to see that my fungus is gone or not. So that is the problem that we are facing at present.
I think there are a lot of uncertainties which are there in COVID and fungal imaging, and many of the patients do not understand that uncertainties when we are reporting that whatever we see sometimes may be the tip of the iceberg. And again, there was a question on follow-up imaging, after 3 weeks, how do we know that it has been completely removed, or how do you know it is completely treated? It's very, very difficult. It is like you have to have slice by slice comparison. You have to use your own judgment. You have to use all the modalities available, both CT and MR, contrast and everything, and try and sort of make yours. There is no way that somebody else in the world can help you with this particular area, where you have to use your own common sense in saying that this is recurrence, this is probably residual disease, this is probably post-op. And then you always keep the option of following it up again. If you're not sure, I think it's better to say that we are not sure at this point of time. Still, follow-up is needed. Murli?
Yeah, sir. In that case, actually, one of the cases which I showed you at last, and was not very sure. I told them just go and do a scopy to see what is there. They went and cleared the crust and everything cleared. It was just a whole blood clot which was under the crust.
Exactly.
So it was as simple as that.
Okay. I think Dr. Hemant has today taught us how to do chest ultrasound. I think many of the radiologists here should think about doing that in their ICU setting and try and help the clinician and ICU team as much as possible. Sir, that is a very, very great eye-opener and a session for us, completely a different thing.
In fact, he started from the basic, taught us the non-COVID ultrasound.
Yes, absolutely. Completely new knowledge and frontier for some of us here.
Yes.
I think all the questions has been answered.
Yes,
if
sir.
I'm not mistaken, then I sincerely thank on behalf of T1PY IRIA, all the faculty who are here, especially Dr. Hemant, because all the others
Thank
are
you. It was a pleasure to meet you all.
Thank you, sir. Thank you, sir.
Thank you so much. Bye.
And of course,
all the best.
Lena for the fantastic post-COVID imaging, and of course, fantastic images and teaching from Sitaraman and Bhavaharan. Excellent discussion from all of you. And thanks all the delegates for being with us. And Murali Krishna, please conclude the meeting.
So you have already thanked all of them, and I think the one
Sorry,
person
I
who we
couldn't
actually
stop
thank is
thanking.
you. Yes, actually, it was Sir's idea to to put up this entire program, and he individually spoke to all the speakers and put the program together. I was little. I think we're almost come to the end of second wave, and but then I think we had so much of insight in this session. That's why I think all the delegates also stayed back, because it was more like a problem-solving session for all practical, all the clinicians who are reporting COVID, especially now with the post-COVID, changes that keep coming, and also now Mucor. So thank you, sir, for putting up this entire session, and once again, thanks to all the panelists for
Thank you all.
Yeah, thank you so much.
Thank you.
And
Thank you.
and
Thank you.
thanks
And
to
there
all
are a
the
lot of thanks and congratulations coming in the chat box and question and answer areas,
Yes.
which means that we all have done at least a pretty decent job today.
Yeah. Thank you so much,
Thank you.
sir. Though we
Bye.
have extended it for almost an hour, I think it was a really great session for all the. Thank you so much, sir.
Bye-bye. All the best.
Thank you, Murali,
Thank
for
you.
coordinating everything.
Oh, my pleasure.
We have to do. Thank you.
Thank you.
Thank you. Thank you.
Thank you, sir. Thank you, sir.
Bye. Bye.
Bye.
Bye. Bye.
Good night.